السلام عليكم ورحمة الله وبركاته. بسم الله والصلاة والسلام على رسول الله. مع حضراتكم الدكتورة لمياء صادق، Consultant Family Medicine TQM and Infection Control Specialist. النهاردة إن شاء الله عندنا كم محاضرة كده لطاف مهمين لكن تقال شوية. إن شاء الله تبقى محاضرات مفيدة، وبسم الله الرحمن الرحيم كده نبدأ مع بعض إن شاء الله. أول محاضرة هنتكلم فيها عن safety in the surgeries, ensuring safe surgery. طيب. بالمختصر كده safe surgery saves lives. الكلام ده مش كلامنا، الكلام ده كلام ال WHO. WHO and surgical safety. WHO has undertaken a number of global and regional initiatives to address surgical safety. Much of this work has stemmed from the WHO's second Global Patient Safety Challenge, Safe Surgery Saves Lives. Safe Surgery Saves Lives set about to improve the safety of surgical care around the world by defining a core set of safety standards that could be applied in all WHO member states. طيب. What's the meaning of the major surgery? What do we mean? Major surgery includes any procedure conducted in the operating room involving the incision, excision, manipulation, or suturing of tissue, which usually requires regional or general anesthesia or profound sedation to control pain. Why are we talking about safe surgery? Why it's important? Surgical care has been an essential component of healthcare worldwide for over the century. As the incidences of traumatic injuries, cancers, and cardiovascular disease continue to rise, the impact of surgical intervention on public health systems will continue to grow. Okay, then, surgery is often the only therapy that can alleviate disabilities and reduce the risk of death from common conditions. Every year, many millions of people undergo surgical treatment, and surgical interventions account for an estimated 13% of the world's total disability-adjusted life years. احنا اصلا بنعمل السيرجري علشان نسيف لايفز. اوكي؟ فلما يحصل من السيرجريز دي complications leading to death, then we have to make it safe to save lives. Then, while surgical procedures are intended to save lives, unsafe surgical care can cause substantial harm. Given the ubiquity of surgery, this has significant implications for public health. In industrialized countries, studies suggest that major complications are reported to occur in 3 to 16% of inpatient surgical procedures, with permanent disability or death rates of approximately 0.4 to 0.8%. In developing countries, studies suggest a death rate of 5 to 10% during major surgery. I think this is a huge number and that really needs correction. There are 5 facts about surgical safety. Complications after inpatient operations occur in up to 25% of patients. A quarter of our patients are complicated in the inpatient. The reported crude mortality rate after major surgery is half to 5%. In industrialized countries, nearly half of all adverse events in hospitalized patients are related to surgical care. But really, it's not a very huge number. It's half of the adverse events, but totally the total percentage is low because they have less adverse events than us. at least half of the cases in which surgery led to harm are considered to be preventable. And here now, that's why we are going to act. It's preventable. So we can reduce these risks to the half. Known principles of surgical safety are inconsistently applied even in the most sophisticated settings. And this is also the reason that we are now talking about this issue and raising awareness about this issue, that it's preventable, and we have to know what are the steps to make it preventable. To this end, working groups of international experts were convened to review the literature and the experiences of clinicians around the world. They reached consensus on 4 areas in which dramatic improvements could be made in the safety of surgical care. What are these 4 areas? Surgical site infection prevention, safe anesthesia, safe surgical teams, and finally, measurement of surgical services. We're going to talk in more details. Surgical site infection prevention remains one of the most common causes of serious surgical complications. Evidence shows that proven measures such as antibiotic prophylaxis within the hour before incision and effective sterilization of instruments are inconsistently followed. These are the basics. Antibiotic prophylaxis within 1 hour before the incision and sterilization of instruments, basics of infection control. Unfortunately, they are inconsistently followed. This is often not because of the cost or lack of resources, but because of the poor systematization. For example, we have antibiotics. Antibiotics are given pre-operatively in both developed and developing countries, but they are often administered too early, too late, or simply erratically, making them ineffective in reducing patient harm. Second thing is safe anesthesia. The anesthetic complications remain a substantial cause of surgical death globally, despite safety and monitoring standards which have significantly reduced unnecessary deaths and disability in developed countries. 3 decades ago, a patient undergoing general anesthesia had an estimated, one in 5,000 chance of death. With improvement of knowledge and basic standards of care, it dropped to one of 200,000 in the developed world. Yes, it's a 40-fold improvement. Unfortunately, the rate of anesthesia-associated mortality in developing countries appears to be 10 to 1,000 times higher, indicating a serious, sustained lack of safe anesthesia for surgery in these settings. The third point is the safe surgical teams. Teamwork is the core of all effectively functioning systems involving multiple people. In the operating room, where tension may be high and lives are at stake, teamwork is an essential component of safe practice. The quality of teamwork depends on the culture of the team and its communication patterns, as well as the clinical skills and situational awareness of the team members. Improving team characteristics should aid communication and reduce patient harm. Finally, is the measurement of surgical services. A major problem in surgical safety has been a shortage of basic data. Efforts to reduce maternal and neonatal mortality during childbirth have been critically reliant on routine surveillance of mortality rates and systems of obstetric care to monitor success and failures. We don't have data like this, so it's more challenging. But similar surveys had generally not been undertaken for surgical care, so data on surgical volume are available for only a minority of countries and are not standardized. Routine surveillance to evaluate and measure surgical services must be established in public health systems or to ensure progress in improving the safety of surgical care. The 4 working groups defined 10 essential objectives that should be met by every surgical team during surgical care. These objectives were summarized in a 1-page checklist for use by healthcare workers to ensure that the safety standards are met. Here are the 10 objectives we are going to talk about. First, the team will operate on the correct patients at the correct site. Then, the team will use methods known to prevent harm from anesthetic and administration while protecting the patient from pain. Then the team will recognize and effectively prepare for life-threatening loss of airway or respiratory function. The team will recognize and effectively prepare for risk of high blood loss. The team will avoid inducing an allergic or adverse drug reaction known to be a significant risk to the patient. The team will consistently use methods known to minimize risk of surgical site infection. The team will prevent inadvertent retention of sponges or instruments in surgical wounds. The team will secure and accurately identify all surgical specimens. The team will effectively communicate and exchange critical patient information for the safe conduct of the operation. And finally, the last objective is for the hospitals and public health systems will establish routine surveillance of surgical capacity, volume, and results. Here, I'd like to add a very short video to conclude what I talked about.
Parasite surgery. Surgery, one patient. Splash left in wound. Can be avoided. Routine splash contractions for the surgery. Operating on a patient and client using pre-verification, hit marking, and anti-analog process. Many anesthesia administration while protecting the patient from pain. Recognize and effectively preparing for the loss of air or respiratory function. Recognize the risk of loss. Avoid inducing an allergic drug reaction. Surgical life infection. Prevent retention of instrument and sponges in surgical wounded using effective pre-and post-surgery process. Secure and correctly identify surgical specimens. Effectively communicate critical information. Routine surveillance evaluation of surgical capacity and results.
Now back again to our lecture. What are the 5 steps to safer surgery? The 2008 WHO Surgical Safety Checklist is essentially a process for improving communication between surgical teams. It involves 5 steps: briefing, sign in, sign out, and debriefing. What's the meaning of these and how to apply these is what we are going to talk about now, and that's the main thing in our lecture, inshallah. Briefing. The aim of the briefing is to confirm the order of the operating list, to delegate tasks, and to confirm that everyone knows their role during the procedure. زي اللي بيحضر لمسرحية كده، لازم يكون المخرج متفق مع كل التيم مين هيقول ايه وامتى وليه وكل واحد دوره على المسرح ايه. تمام؟ هو ده اللي هيتقال في البريفنج قبل ما ندخل المعرض، قبل ما نعرض في المسرح هنعمل بريفنج كل واحد التاسك بتاعه ايه. The whole surgical team should receive a thorough, focused, and supportive briefing before any procedure. They should feel free to ask any questions and raise any concerns they might have. Senior staff members should actively welcome queries from junior staff members. السيناريو كمان بيتحط على الحاجات اللي مش متوقع ان هي تحصل، يعني اللي هو بعد الشر اذا حصل كذا مين دوره يعمل ايه، اذا حصل arrest مين هيعمل ايه. فالسيناريو بيتحط كامل حتى لو حاجات ان شاء الله ما حصلتش بس لازم تكون محطوطة في السيناريو. The briefing should take place in a quiet room with a closed door so as to ensure patient confidentiality. Any member of the team can lead the briefing and they must encourage an atmosphere of open communication. دي أرواح ناس، يعني الموضوع ما فيهوش هزار ولا تهريج ولا كسوف، في أرواح ناس. The briefing should begin with all members of the team introducing themselves. When discussing the patient, they should be referred to by name. Next should be an overview of the operating list, and all members of the team should have received a copy of this before the briefing. In this way, you can consider any questions and concerns in advance. The next step is the sign-in. بدأنا ندخل في الجد. The sign-in, the aim of the sign-in is to ensure that all necessary preparations for surgery have been made and that it's safe to introduce anesthesia. So, all other activity must stop before the sign-in to allow the anesthetist and operating department practitioner to give it their full attention. The sign-in process is a series of questions. The first question is, has the patient confirmed their identity, site, procedure, and consent? Is the site marked? Is the anesthesia machine and medication check complete? Does the patient have a known drug allergy? Does the patient have a difficult airway or an aspiration risk? Is there any risk of blood loss? These questions should be read aloud, and where necessary, the patient should be involved in the discussion. If any item in the list needs clarifying, then it must be done immediately, and the sign-in process should be repeated from the beginning. anesthesia should only commence once the sign-in is complete with all the discrepancies resolved. Here is a checklist before induction of anesthesia. This is the sign-in. If we use this checklist, we will not lose items that may harm our patients. And we are now, if all here are checked, we did our sign-in process, and we can go through the anesthesia process, induction of anesthesia, I mean. So, in conclusion, we will check if the patient has confirmed the identity, site, procedure, and consent. The site is marked or it's not applicable. طبعا في بعض الحالات إن هو site حاجة inside, how to mark this. And anesthesia safety check completed. The pulse oximeter is on the patient and functioning. And these questions are answered about known allergy, difficult airway or aspiration risk of blood loss more than 500 ml. The third step is the time out. The aim of the time out is to ensure that the surgical team is undertaking the correct procedure on the correct patient and that all the correct measures are in place to prevent harm. As with the sign-in, all activity must stop to allow the team to focus on the time out. It should begin once the patient has been safely positioned with all necessary monitoring attached. This is another series of questions which again should be read aloud from the list and not from the memory. مش هقول ايه يلا انا هسمع، لا. تشيك ليست زي اللي فاتت دي بالظبط كده. تشيك ليست ونحط صح على كل واحد. There's no place here for personal faults and forgetfulness. This is a life issue. First, confirm that all team members are present and that all have been introduced by name and rule. احنا واقفين مش عارفين مين فلان ومين فلانة. طيب أنا لما أطلب إيه أطلبه من مين؟ لا، الأيتم ده لازم يكون واضح وكلير قبل ما العيان يتفتح. مين هنا اللي مسؤول عن إيه ومين هنا مسؤول عن إيه ونداه باي نيم. أنا عارف هو مين وعارف إيه الريسبونسبيلتي بتاعته. أنا عارف وهو كمان عارف. Confirm the patient's name, procedure, and incision site. Anticipate critical events for the surgeon and the anesthetist and the nursing team. Ensure that all essential imaging is displayed, including X-rays, CT scans, and MRI, to reduce the risk of wrong site surgical marking. Surgery should only commence once the time-out process has been successfully completed. Now, here is our second checklist, the time-out checklist. Before skin incision. First, confirm all team members have introduced themselves by name and role. Then, surgeon, anesthesia professional, and nurse verbally confirm the patient, the site, the procedure. Then, anticipated critical events. Surgeon reviews what are the critical or unexpected steps, operative duration, and anticipated blood loss. The anesthesia team reviews, are there any patient-specific concerns? And finally, the nursing team reviews, has sterility been confirmed? Are there equipment issue, or any concerns? And finally, has antibiotic prophylaxis been given within the last 60 minutes? Yes or no? Or it's not applicable? Is essential imaging displayed? Yes or not applicable? Now we are going to the next step, which is the sign out. The sign out. The aim of the sign out is to ensure that the surgical procedure has been completed in its entirety and documented accordingly. This step also ensures the patient's ongoing safety beyond the theater. Again, all activity must stop to allow the whole team to focus on the sign out. نفس الكلام. And the sign out must be completed before any member of the team leaves the operating theater. The patient should also remain in the theater until any discrepancies has been resolved. It's once again, in a case of reading a series of questions aloud from a list, a surgical nurse should begin by verbally confirming the name of the procedure before conducting thorough instrument, sponge, and needle count. Then comes the specimen labeling process, and the nurse should read all specimen labels aloud, including the patient's name. They should also confirm whether there are any equipment problems to address. And finally, the surgeon, anesthetist, and nurse should confirm the key concerns for the patient's ongoing recovery and management. Here is our checklist for the sign out. When to use this? Before patient leaves the operating room. Nurses verbally confirms with a T the name of the procedure recorded, that instrument, sponge, and needle counts are correct, how the specimen is labeled, whether there are any equipment problems to be addressed, the surgeon, the anesthesia personnel, professional, and nurse review the key concerns for recovery and management of this patient. Now we're going to our last step, which is the debrief. The aim of the debrief is to allow the surgical team to review their performance, to identify achievements along with any areas that may need improvement. Like the initial briefing, the debriefing should be attended by everyone. The atmosphere should be professional, yet open, welcoming, and supportive. If any actions are identified, there should be a clearly identified person appointed to deal with it. This way, everyone will know their responsibilities, which will make it much more likely that any problems will be addressed. By now, our first lecture is done, alhamdulillah. And if there's any question or any clarification needed, please, you are welcome. الله يعافيكم جميعا. I wish إن هي كانت concise, brief and clear. If there's no other, if there's nothing to discuss about this, I prefer to go on to the next lecture. It will be very quick also, inshallah, because our next lectures will need more clarification, inshallah. Okay. Now we are going to talk about the risk of patient harm resulting from faults. How to reduce the risk of patient harm resulting from faults. Okay, I'll share a small video also to well, let's see.
May result in injuries, unintended procedures, hospital stays. Our hospital we strive. Here's something. You were there. Place with this reassess when there is a change in your condition. For example, consuming medication causes drowsiness, brain state, each assessment, the result is reported. Instead, as the compound person, there's daily you may be at risk of hospital. It sounds safe. You'll be better. You can still fall. So don't cry.
مش عارفة هل الصوت بس بتاع الفيديو اللي كان غير واضح ولا أنا كمان صوتي غير واضح؟ أوكي حاضر. حاضر. أوكي طيب تمام. خلاص هنقول الكلام ده حاضر. هو بس الفيديو كان علشان تبقى حاجة مختصرة كده سريعة فيها أكشن بحيث الكلام يبقى سهل وإحنا بنتكلم فيه. بس حاضر مع بعض. طيب What's the definition of fall? Loss of upright position that results in landing on the floor, ground, or an object or furniture, or a sudden, uncontrolled, unintentional, non-purposeful downward displacement of the body to the floor, ground, or hitting another object like a chair or stair. There is a fall response team should be there in the hospital. This fall response team is comprised of interdisciplinary team members that are activated following a fall to evaluate circumstances surrounding a fall with the goal of reducing risk factors. طب يعني احنا خلاص حصل الفول، احنا في حتتين دلوقتي، احنا عايزين prevent الريسك اوف الفول. طيب هبريفنت حاجه ازاي وانا لسه مش عارفه ايه الريسك فاكتورز بتاعتها وايه اللي ممكن يكون بيحصل، فانا اعمل له اناليسيز علشان اعمل له بريفنشن من الاول. عشان كده بيبقى فيه فول ريسبونس تيم بيحلل ايه اللي حصل ادى الى هذا السقوط، وبيحلل مع كل حاله الريسك ده وصل لحد فين، ادى الى ايه اصلا، وبناء على النتيجه اللي حصلت للبيشنت ده بيبدا يتخذ اجراء، اما ان هي حاجه بسيطه او حاجه ميجر. ولو هي حاجه ميجر لازم يعمل حاجه اسمها روت كوز اناليسيس ويكول فور ذات، ونبدا نشوف ايه الخطوات اللي انا لو عملتها اتجنب حدوث هذه المشكله لاحد العيانين تاني. طيب in brief, fall response teams are comprised of interdisciplinary team members that are activated following a fall to evaluate circumstances surrounding a fall, with the goal of reducing risk factors and preventing a repeat fall. This team examines the environment, equipment, fall program elements, and resources, including staffing, surveillance, communications, and knowledge of risk factors that may have contributed to the event. The team makes immediate recommendations to reduce fall risks for an individual patient. We have to assess the level of injury. Is it none? Then it will equal 0. Or is it a minor injury like some bruise, abrasion, minor lacerations? Then it will be scored like 1. Or is it a major injury? There is a hip fracture occurred or head trauma or arm fracture, then it will be categorized as 2. And finally, is the disaster, if the fall led to death, then it will be categorized as 3. So we have to check what's the post-admission fall occurrence. A fall that occurs after a patient is admitted to an inpatient setting. يبقى دي حصلت عندنا خلاص، هو admitted عندي في الانبيشنت وحصلت الفول دي، فانا لبست فيها بقت post-admission fall occurrence. في انواع من الفولز، في slip هو مجرد loss of balance as a result of a slippery surface that does not result in a fall. يعني زي اللي بيتزحلق كده ويمسك نفسه ما وقعش totally، هو مجرد زحلقه كده slip. Stumble, loss of balance due to knee giving way or other reasons but does not result in a fall، اللي بنسميها كده رجله خانته، الركبه كده ايه جايه يقف ما وقفش عليها عادي. The trip is loss of balance due to a specific obstacle that does not result in a fall. الكعبل في حاجه، الكعبل بقى في سلك طويل، الكعبل في سجاده على الارض، بس الحمد لله ما وقعش. اوكي، ده غير الفول. احنا اتكلمنا الاول على الفول اللي هي فول وقع، لكن دي ما قبل الوقعه، ودي برضو has to be assessed علشان نبقى واخدين خطوه استباقيه ان احنا how to prevent these before occurrence. طيب فبنعمل ايه؟ بنعمل risk assessment. بنحسب ايه الفول ريسك، نشوف كده ايه الريسك فاكتورز اللي ممكن تخلي البيشنت عندي في الفاسيلتي يقع. اما انها تكون extrinsic factors or intrinsic factors. Much work has been done to identify the risk factors associated with the likelihood of a patient falling. These risk factors are generally categorized into extrinsic, and it's factors outside the patient's body, and intrinsic. Intrinsic is there in the patient's internal and psychological factors. Examples for extrinsic factors are hazardous activities, time of the day, external lighting, clutter, spoils, and loose electrical cords. يعني for example, مثلا the time of the day, mostly in the night times, sleepy patients and يعني dark environments that will cause more risk for the patient to fall. This is external factor. Like external lighting, some places use يعني lights that are not giving clear vision for the patients, especially those with visual problems. So using good lighting in hospitals is very important. Unlike in the hotels, you see يعني the lights are very يعني كده تحس ان هو لايتس خفيفه. لا الكلام ده ما ينفعش في مستشفيات. المستشفيات محتاجه جود لايتنج، يبقى الليل فيه زي النهار. كلاتر، كل ما كانت الدنيا دوشه اكتر حوالينا وفيها ضوضاء عنيفه وفيها، كل ده بيزود الفاكتورز تو فول. طبعا لو في spoiling with water or body fluids or anything makes it more slippery and more dangerous. Any loose electrical cords, the rugs, wherever, anything that are thrown anywhere is not in place, using too much furniture, all these increase the risks for the patients to fall. Right? And not only the patients, we are talking about all those who are there in the hospital, also the staff and the visitors, who are talking about the safety for all. Okay, what about the intrinsic factors? Intrinsic factors, as we said, it's related to the patient itself. It's about the muscle and strength weakness, gait and balance disorders, visual disturbances, cognitive impairment, mental states alterations, dizziness, vertigo, postural hypertension, incontinence, polypharmacy, age, chronic disease. All these factors are related to the patient itself. And for example, if we have more than one disease on the list, we usually call it as a secondary diagnosis. We mean here by secondary diagnosis that he have يعني like comorbidities. When the patient has more than one disease, he's more liable to have يعني his fall risk is higher. And aging is a problem also, because we face it with old age patients. When you're getting above 65, you have almost 2 to 3 times more full risk than younger persons. And the other thing is the hazards. يعني you are more liable to fall and you are more liable to get hurt from this fall because of many factors, because the muscle weakness sometimes and other comorbidities. The polypharmacy, many medications may increase the risk of fall, like diuretics, for example, may increase the risk of postural hypertension. So here, the risk of falls will increase. Okay, what to do? We have to measure for every patient the risks of the fall. Then we have to take an action to prevent the fall according to these measurements. We have many scales for measuring the risk of fall for the patients. Now we are going to talk about maybe the most familiar scale for measurement of the risk, which is called the Morse fall scale. This is the nursing force risk assessment. Diagnosis and interventions are based on use of the Morse fall scale. The Morse fall scale is used widely in acute care settings, both in hospitals and long-term care inpatient settings. The Morse fall scale requires systematic, reliable assessment of a patient's fall risk factors upon admission, fall, change in status, and discharge or transfer to a new setting. تاني احنا بنستخدم ده امتى؟ المورس فول سكيل بنستخدمه امتى؟ والعيان داخل بس؟ لا، بنستخدمه upon admission. طيب وبنستخدمه لو حصل فول فبعمل ري اسسمنت للمورس فول سكيل. هيفرق؟ هنعرف دلوقتي انه هيفرق. about change in status، هو كان داخل لي conscious ومش عارفه ايه وايه وايه وحصل arrest وهو دلوقتي مثلا post arrest او عنده مثلا stroke event فحصل change في البتاع وبدأ ان هو عملنا له هيموليسيس فالدنيا بدأت تتحسن فبدأ يتحرك فيبقى كده في change in status. discharge او transfer ل new setting، انا خرج من عندي راح another setting، we have to reassess المورس full scale، or العكس ان هو جالي الفاسيلتي فانا هعمل له new assessment of the Morse full scale even لو هي كانت معاه سابقا. اوكي، يبقى دي occasions اللي we have to use the Morse full scale. طيب Morse full scale subscales include assessment of ايه ده بقى؟ احنا بنأسس the history of falling immediate or within 3 months. عشان كده هنا لما قلنا ان after fall ممكن يحصل change في السكيل، طبعا لان هو لو هو never fell before he will take 0. If he has a history of falling then he will take a score of 25. We will assess every one of these 6 elements and give a score and calculate the total of this score to know the way of the risk for this patient. Here, if he had a falling history before, then he will take 25 points. If he has a secondary diagnosis, as we said before, that secondary diagnosis here we mean about he has more than one morbidity, يعني he has comorbidities, so he will take 15 points. He is using an ambulatory aid if no, or he's in bed or using wheelchair or the nurse there to help him, so we will put 0. But if he is using his cane or walker or crutches, he will take 15 in the risk. Or if he is using the furniture, he will take 30. That means if he is bedridden, it's okay for now. For us, it's okay. He's bedridden. He will not go out. I will not go to the bathroom. So we will take 0. If he is not ambulating around without the nurse's aid, so خلاص. He is always calling for the nurse. He is using the wheelchair. All this reduce this risk. طيب. If he is using crutches or cane or walkers, so the risk of fall will increase and he will take 15 points. But if he is not walking well and taking the help of the furniture, here the risk really increases because the furniture sometimes is not there so close for him to use it, or it's not steady enough to use it. He may use the chair and the chair gets on the back and he fell down. So now here's really an increased risk. Okay. If he is using IV or Heparin lock, here we have a risk of 20. The gait or transferring, if he's normal or immobile, he's in the bed, so there's no risk. If he's weak, there is a risk of 10 marks will be added. If he's impaired, there is a risk of 20 will be added to the scoring. The mental status, if he's oriented to own ability, خلاص, there's no problem. He knows that he can do it, then it's okay. He knows that he cannot do it, so he will not try. But if he forgets the limitations, then there is a risk of fall here. So we will add 15 marks on this point. Then we will calculate the marks from all these and get the risk level. From 0 to 24, we count it as there is no risk and there is no action will be taken. If from 25 to 50, there is a low risk of fall, so we will use the standard fall prevention interventions. And if it's more equal to 51, so it's a high risk, and now we will use the high risk fall prevention interventions. Standard fall prevention interventions. Interventions suggested for implementation include both standard and high risk interventions specific to the patient's fall risk score. We said patients who are scored low risk on the Morse fall scale from 25 to 50 will have the following interventions implemented by the nursing staff. So here is the golden rule. Our nurses are our helpers, and not only helpers, maybe their actions are hidden, but everything is really relied on their back. Without good management from our nurses, without their work that comes out from their hearts with love and passion and care about patients, really, we will suffer and our patients will be really harmed. If you look at each process in the hospital, you will find the main soldier in the process is our nurses. So here, one of their points that can save lives. This is the standard prevention, and all maybe relied on their shoulders. The direct care. At the start, they will assess the patients for risk upon admission, as we said, and upon change in status, as we said, transfer to another unit or discharge. They will assign the patient to a bed that enables the patient to exit toward his stronger side whenever possible. That means if the patient has weakness in the left side, so you will find the strains in the left side of the bed are up there, so he cannot go from his left side. So inshallah, he will not fall from the left side. So he has to go in the right side because it's the open one, it's the open gate. They will assess the patient's coordination and balance before assisting with transfer and mobility activities. And they will implement bowel and bladder programs to decrease urgency and incontinence. They're not going to wait for a full bladder and the patient is in urgency and he has to go now to the bathroom, and this will increase the risk fall. So they have to use this program, go in scheduled times to take the patient to the bathroom before getting this feeling as an urgent feeling. And they are going to use treated socks for all patients. It's again slippery, and some types of socks that helps against slippery. For all the staff, they will approach patient towards unaffected side to maximize participation in care and transfer patients towards stronger side. Education. Actively engage patients and family in all aspects of fall prevention programs. Instruct patients in all activities prior to initiating assistive devices. Teach patients use of grab bars. Instruct patients in medication, time, dose, side effects, and interactions with food medications, other medications. Equipment. Look all movable equipment before transferring patients. Individualized equipment specific to patients' needs. Environment. Place patient care articles within reach. Provide physically safe environment. Eliminate spills, clutter, electrical cords, and unnecessary equipment. Provide adequate lighting. Then the medical staff evaluate and treat gait changes, postural instability, spasticity. Initiate treatment for impaired vision and hearing. Evaluate medication profile for forward risk. Evaluate and treat pain. Evaluate and treat orthostatic hypotension. Assess and treat impaired central processing like dementia, delirium, stroke, and perception problems. High-risk fall prevention intervention. These interventions are designed to be implemented for patients with multiple fall risk factors and those who have fallen. These interventions are designed to reduce severity of injuries due to falls, as well as to prevent falls from reoccurring. Supplementing standard fall prevention interventions. Now our second lecture الحمد لله كده خلصت. إن شاء الله تكون سهلة، معلوماتها بسيطة خفيفة. You are welcome to ask any questions about these two lectures for now. طيب سؤال، هو أنا بتكلم بسرعة يعني هل كلامي مفهوم أو محتاج شرح زيادة more clarifications ولا it's okay علشان نخلص على طول؟ و يعني ممكن توقفوني لو في حاجة وقفوني فيها. طيب شكرا، جزاكم الله خير. هو الحقيقة أيوة المعلومات كتيرة وأنا مختصراها اختصار على قد ما قدرت، لأن فعلا محاضرات النهاردة حقيقي تقيلة وطويلة المفروض، بس أنا منقية أكتر حاجات ممكن تكون تهم أغلبنا ومن واقع الشغل يعني، لكن يعني حاضر هحاول أختصر. الله يسعدكم جميعا. طيب إيه رأيكم ندخل في المحاضرة الثالثة كده؟ بس هي المحاضرة الثالثة بقى إيه؟ محتاجة شغل وتركيز، وإن شاء الله هيبقى فيها interaction together. إيه رأيكم نبدأ؟ توكلنا على الله. بسم الله الرحمن الرحيم. Just culture promoting safety and competence. What's the meaning of just culture? احنا عندنا actions أو يعني display what has happened in the past and the present And what do you want? In the past, the culture of healthcare in the past focuses on placing blame on healthcare providers whenever there was an error or bad outcomes occurred. With this kind of culture, healthcare providers were hesitant to report any errors due to fear of punishment. As a result, such occurrences were never reported. احنا مثلا لسه متكلمين في المحاضرة اللي فاتت عن الفول ريسك او عن ال how to save lives ان ما يحصلش مشاكل في السيرجريز. طيب اذا ما فيش ريبورتنج، اذا انا ما قلتش ان حصل unsafe practices في السيرجريز مثلا، كيف سأتجنب وقوع هذا الخطأ ثانية؟ طيب ايه اللي يخليني ما اعملش ريبورتنج؟ اللي بيحصل ان انا لو عملت ريبورتنج هتنفخ. So that what was really used in the past. طيب we are trying to make a blameless culture. في مرحلة كده دخلت في النص. To improve reporting of errors, organizations moved to blameless culture. However, this type of culture didn't succeed due to lack of accountability, and the practice didn't promote a learning environment that promoted patient safety. يعني إيه؟ يعني إحنا في الأول كنا ندور كده، حصل مصيبة، عيان دخل العمليات مات، فكان إيه اللي يحصل؟ كل واحد يحاول يدور على مين اللي هيلبسه في الموضوع دوت علشان يبقى فلان هو السبب وده خطأ فلان، وده كان البليم كلتشر اللي كنا بنتكلم عليها. بعد كده قلنا لا 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 لا، ده كل المشاكل هي مشاكل سيستم، ما هو السيستم لو كان صح ما كانش حصل كذا، وده بقى البليملess كلتشر. حصل ايه؟ حصل ان بقى بعض الناس تتكل على ان احنا في بليملess كلتشر وانا مش هتعاقب، فبقيت اعمل تصرفات ريكلس وغير مسؤولة، تصرفات غير مسؤولة، فأدت إلى إن كل حاجة متعولة على إن المشكلة في السيستم، بس هو في مشكلة في الناس برضو. فعلشان نعمل تحول من هذا الفكر وذاك، وصلنا إلى حاليا الفوكس of the healthcare on the patient safety and just culture. يبقى في عدالة، في بالانس ما بين مشاكل السيستم ومشاكل الهيومن behavior. Balance the assessment of systems, processes, and the human behavior when an error or event is reported. احنا لو فهمنا النقطة دي إن شاء الله بقية المحاضرة كلها هتبقى سهلة جدا. What is the just culture? The term just culture refers to a safety supportive system of shared accountability, where healthcare organizations are accountable for the systems they have designed and for responding to the behaviors of their staff in fair and just manners. Staff, in turn, are accountable for the quality of their choices and for reporting both their errors and system vulnerabilities. Goal of just culture. The goal of a just culture environment is to design safe systems that will reduce the opportunity for human errors and capture errors before they reach the patient. Safe systems should facilitate the staff to make good decisions and should make it more difficult to make an error. كأني بحط عوائق ما بين حدوث الerror ما بين البيشنت. However, it's up to individuals to manage their behaviors and choices. just culture environment is an environment where negligence is identified and disciplines applied appropriately after a systematic review of the error. حضرتك أهملت وبناء عليه هيحصل disciplinary action هتبقى punished. طيب, to ensure a fair and just process, an established set of objective questions follow an algorithm to identify if the error occurred due to a system or process issue and or due to a human error. يبقى حصل لي event أنا هعمل analysis للإيفنت ده وأعمل root cause analysis and then I will take some questions like the 5 whys or whatever. We will discuss it inshallah later today. And after answering these questions, I'll know, is it a system error? Is it because of our system is not going well, so we have to improve our system, or it's a human error? Staff is held accountable for their actions or behaviors. Staff is not at fault when there is a system or process that allow the error to happen. Okay? Just culture environment recognizes that competent professionals make mistakes. هو مين ما بيغلطش? And acknowledge that even competent professionals will develop unhealthy norms, shortcuts, routine rule violations, but has zero tolerance for reckless behavior. ومفيش حد ما بيغلطش. فالhuman error will happen because we are humans. لكن مش هقول أصل ده خطأ طبيعي. لا، أنا لما بعمل analysis في human error وفي negligence والreckless behavior، ده تصرف متهور أحمق ما يطلعش من شخص طبيعي متحمل المسؤولية. Just culture supports a learning culture and focuses on proactive management of system design and management of behavioral choices. يعني إيه proactive؟ يعني استباقية، يعني أنا أتوقع الحاجة قبل حدوثها وأعمل actions إن شاء الله تمنع حدوث الحاجة دي. ما بقاش دايما ردة فعل، حصل كذا طب هنعمل كذا، فلان غلط طب نعاقب، مش عارفة إيه طب لا، إحنا proactive، إحنا حاطين في بالنا لو حصل إيه الأكشن المفروض يتعمل أو نعمل إيه علشان ما يحصلش أصلا الإيرور ده. طيب، طبيعي زي كل حاجة في الدنيا بيبقى ليها barriers. الكلام حلو وجميل بس أكيد في barriers. What are the barriers to the just culture? عندنا 4 major barriers to creating a just culture. البليم هو في دمنا برضه، هو السبب. انت عملت كذا ليه؟ الشيطان هو كده. طيب، blame lack of transparency, outcome bias, inconsistent assessment processes. برضو بيجي فيها عوامل بشرية كتير، اللي هو مثلا أنا هعمل RCE root cause analysis وهنعمل بقى إيه قاعدة كده وبرين ستورمينج ومش عارفة إيه وهنجمع إيه اللي ممكن يكون السبب في كذا. لقيت إن فلان اللي هو عزيز عليا قوي ممكن يكون محطوط في RCA فشلتها من RCA وهكذا. ففي أحيانا inconsistency في الاسسمنت بروسيس. عشان كده الموضوع كمان بيحتاج قدر كبير من الشفافية والأخلاق علشان يبقى there is a just culture، لأن هي كلها معتمدة على خطوات. احنا مش we are not going to blame someone but we are seeking for more analysis to check if there is a system problem or a human error. an objective model for dealing with human errors and breaches, decision paths for allocating responsibility to either the system or the individual based upon duty, not based upon severity of the outcome. يعني طيب احنا هندخل في حتة السيفيريتي اوف ذا اوتكم ديت later علشان نفهم هو احنا يعني مش مسألة ان دي so severe فدي مثلا هتبقى system error أو لا احنا عايزين نallocate responsibility is it a system or individual error اوكي خلاص based upon كل واحد دوره ايه يعني هل مثلا حصل الخطأ ده هو خطأ طبي لما عملنا بير ريفيو قالوا لا والله هو الاكشن اللي عمله الطبيب الفلاني كان مش مظبوط قوي وكان المفروض ان هو حسب الداتا اللي قدامه مع البيشنت ده كان المفروض يعمل الحاجه الفلانيه. هل ده عيب في السيستم؟ لا، ده عيب في الديسيجن خده الانديفيدوال. تمام، بغض النظر بقى العيان مات ولا ما ماتش ولا كانت نير ميس اصلا ولا ما حصلش حاجه بس احنا عايزين نتعلم من اخطائنا ويبقى فيه learning culture whatever. احنا عايزين نحدد هي individual or system problem بغض النظر عن severity of the outcome. Foundational assumption about risk. Humans will make errors. خلاص, humans will make errors and drift into at-risk behaviors as they become comfortable with processes. Risk is managed by monitoring and measuring errors. Judged using our values against what another reasonable person in a similar situation would do. زي ما قلنا كده زي ال peer review مثلا. لو انت مكاني كنت عملت ايه؟ Just culture is about creating an open, fair, and just culture. Creating a learning culture. Designing safe systems. Managing behavioral choices. لحظة واحدة بس كده هحاول أجيب الفيديو ده.
Evidence strives to keep its patients safe. In a perfect world, this would mean no patients could ever be harmed, but humans make mistakes. Treating the human body is extremely complex. And given the scale of the human case, dealing with over 1 million patients every 36 hours, there are many reasons why things can go wrong. When things go wrong, the most important thing for safety is that there is a culture that encourages everyone to identify the underlying causes to prevent similar incidents being repeated. Unfortunately, it can be a tendency to single out the member of staff most closely involved in the incident and to focus on the incident happening across the night. That's the wrong approach. When a behaviour safety incident occurs, it is rarely the fault of an individual knowing and keeping an unsafe environment as well. In the vast majority of cases, things go wrong because of failures in organizations, systems, and processes. People will always make mistakes, so our processes should rely on individuals to be infallible. Evidence in safety science shows that it's wrong to assume that if people just try harder, they won't make mistakes. Experience from other industries shows that punishing people for making honest mistakes doesn't work. Resorting to blaming individuals is often unfair and is usually detrimental to patient safety. It can create a culture of blame where staff are reluctant to report and learn mistakes. Then leaves the root cause of the incident unaddressed, with the risk that more patients will be harmed by the same mistakes. We need to ensure that we are treating staff consistently, constructively, and fairly. A just culture guide has been launched by NHS to support managers to do this. The guide builds on the work of Professor James Wilson, an expert in human error and is based on national patient safety agencies, incident discipline. It uses principles developed from decades of research to human factors, as well as feedback from patients, clinicians, and experts. A just culture guide sets out a series of questions and recommendations that require managers to consider next steps for an individual using investigating patient safety incidents against a suggested concern about an individual's action. The guide does not replace any prior advice or existing organisational policies. It should work with them, and if used correctly, the guide should set managers on course to make a fair decision about the next steps. It also provides a useful check against unconscious bias, ensuring all staff are treated the same regardless of seniority of the staff group. The guide is consistent with the approach being taken by a number of NHS trusts to reduce the disproportionate disciplinary action against black and minority staff. Involvement in a patient safety incident can be very stressful for everyone. The patients are never families, but also the staff involved. What involves the way it has the best chance to improve patient safety. Being open and fair helps ensure we're not honest about what went wrong and helps to keep the really safe.
هو أنا حقيقي مش عارفة ليه الصوت ما بيبقاش واضح لما بعمل شير، بس أنا الفيديو ده بعت الرابط بتاعه. حضراتكم إن شاء الله تقدروا يعني تتفرجوا عليه وتسمعوه بصوت أوضح يعني بيرسونال. أوكي، إيه ده؟ نرجع من الأول تاني ليه؟ أوكي، لا أنا قصدي صوت الفيديو يعني. طيب، the just culture model. أول حاجة هنتكلم على mission and values, then the duty, the breach, the consequences. The mission: to contribute to the health of our community through the provision of quality services delivered in a compassionate and cost-effective manner. We collaborate with others in the community to improve the quality of life. The values: dignity, collaboration, justice, stewardship, and excellence. We have 3 basic duties. The first is the duty to produce an outcome. Please concentrate in this slide, please, because it's really important. Duty to produce an outcome. If an individual knows the desired outcome, they should be able to produce it. Like safe removal of an inflamed appendix. يعني على سبيل المثال. Failure to do so represents breach of this duty. Did the employee breach a duty to produce an outcome? احنا دلوقتي قلنا ان احنا هنجمع data عن الحاجة اللي هتحصل عشان اعرف is it a human error or a system error. طيب لما هنيجي بقى في الهيومن errors، انا علشان احكم انا عندي duties: the duty to produce an outcome, the duty to follow a procedural rule, and the duty to avoid causing unjustifiable risk or harm. طيب ايه هو الديوتي؟ ان انا produce an outcome. انا دلوقتي surgeon داخل اعمل عمليه appendectomy لعيان، المفروض ان انا اكون عارف ايه الاوتكم منها. ان انا هشيل الانفلامد appendix واقفل العيان من غير ما اعمل له infection مثلا، والحقه اعمل له العمليه قبل ما هي ترابشر ويدخل في سيبتيسيميا ولا whatever، ويطلع من عندي صاحي، ما يطلعش على يعني تمام، يطلع من عندي عيان، يطلع من عندي على الورد سليم يعني صحي، ما يموتش يعني. تمام، فانا عارف الاوتكم. فلو انا عارف ايه هو الديزايرد اوتكم اصلا، هعرف اوصل له ازاي. طب لو انا مش عارف اصلا اعمل عمليه الابنسكتومي دي ازاي، اوكي، وفي failure to do this this action, this duty، فانا كده هبقى عندي failure to produce the outcome. العيان دخل من عندي، المفروض مثلا ان انا كنت اشتغل دلوقتي، انا اشتغلت متاخر بعدها بيوم، ربشره الابندكس، مش هو اللي جالي متاخر، لا هو كان عندي وانا ما عملتش الصح فربشرت، فالعيان حصل له complications whatever. المهم ان انا في الاخر كده I failed ان انا اوصل للاوتكم المنتظر اللي كان المفروض اعمله. failure to follow a procedural rule if the individual knows the proper procedure and it's possible to follow the rule. زي the procedure of inserting a central venous catheter. Failure to do so represents a breach of this duty. انت عارف الخطوات، تمام؟ لو انت ما مشيتش على الخطوات يبقى انت ما مشيتش على البروسيجرال رول، يبقى ساعتها انت غلطان. Did the employee breach a duty to follow a procedural rule in a system designed by the employee and by the employer? The third duty is the duty to avoid causing unjustifiable risk or harm. Breach of this duty occurs when an individual intentionally harms the patient or acts recklessly. Did the employee put an organizational interest or value in harm's way? بمعنى أنا لو عملت حاجة unintentionally ممكن أتعلم منها الخطوة الجاية، لكن if I act with reckless behavior and I intentionally harm the patient, so now I breach the duty of يعني to avoid causing unjustifiable risk or harm. طيب. Why it's important this? Because we will have some scenarios and it's expected from you to help me to check where is the wrong stage that happened, where is the duty breached. Okay, so I need you to concentrate about this to help inshallah in the scenarios, to contribute with me inshallah. Just culture, expectations of staff. Look for risks in the work environment. Report errors and hazards. Help design safe systems. Make safe choices that align with organizational mission and values. ما تقولش أنا مالي. تمام؟ It's just culture. Culture يعني مش واحد لوحده، مش مدير، كلنا. Okay, it's just culture. So we all have to look for the risks in the work environment. We all have to report the errors and hazards. We all should work together and help to design a safe system. And we all should make safe choices that align with the organizational mission and values. What about breaches? What are the kinds of breaches we are going to talk about? Organizations must recognize that humans make mistakes. It's the behavior choices that must be managed. إحنا كلنا هنغلط. بس نوع الغلط ده إيه؟ The behaviors that are expected when assessing an event are: it's either a human error or at-risk behavior or reckless behavior. What's the meaning of this? The human error: inadvertent action, inadvertently doing other than what should have been done, like a slip, lapse, mistake. كلنا خطائين. But there is an at-risk behavior. It's a behavioral choice that increases risk where risk is not recognized or is mistakenly believed to be justified. هو الموضوع اتلحق وما حصلش مصيبة وعدت، بس الأكشن ده لو اتعمل بالطريقة دي تاني هيحصل مشكلة، لأن الموقف اللي فات ده كان very close إن يحصل مشكلة. It's at risk behavior. أنت لو فضلت تتعامل بهذا البيهيفير مسير هيحصل مصيبة. أوكي؟ وده بقى مش بناء عن جهل ولا اللي هو مثلا خطأ عادي ولا أصلا أنا عادي سهي عليا. لا، this is at risk behavior. أما بقى الريكلس behavior ده behavioral choice to consciously disregard a substantial and unjustifiable risk. طيب احنا عرفنا البريتش. طب كل بريتش انا هتعامل معاه ازاي؟ حصل البريتش ده، ردة فعل الجاست كالتشر هيعملوا ايه؟ تمام؟ لو هو human error هتعامل معاه ازاي؟ لو هو at risk behavior هتعامل معاه ازاي؟ ولو reckless behavior هنتعامل معاه ازاي؟ بشكل عام الhuman error the product of current system design and managed through changes in choices, processes, procedures, training, design, environment. Here we are going to console. يعني احنا ليه هنا لزقناها في السيستم؟ لان السيستم المفروض كان يعمل as a barrier للhuman errors. بمعنى هو طبيعي لو واحد اشتغل 12 ساعة ولا 13 ساعة طبيعي انه يهنك ويغلط، انت عارف ان ده بني ادم. فلو انت intentionally شغلت الشخص ده عندك مدة طويلة او intentionally شغلت عدد قليل من البيرسونيل على عدد كبير من البيشنتس، انت متوقع ان هيحصل human error. فبالتالي there is a system problem. So we have to console. هنغير ايه؟ هنغير processes مثلا، procedures مثلا، بحيث ان انا اعمل more barriers ما بين يعني human errors patients بحيث ما تحصلش اخطاء as much as possible. اعمل لهم training courses، أحسن في الانفايرمنت، تبقى more comfortable، تبقى اليومينيشن أفضل، whatever السبب اللي أدى للhuman error، أنا محتاج إن أنا أتحكم فيه. طيب what about the at-risk behavior? A choice. Risk believed insignificant or justified. It's managed through remove incentives for at-risk behaviors, create incentives for good behaviors, increase situational awareness. Here, we're going to use the coach approach. Behavior بيتعمل lead to إن أنا بحط patient at harm or it's at-risk behavior. So the outcome is not a sentinel event or a big adverse event. So now I will just coach. Okay, but if the at-risk behavior led to a sentinel event, now we will act like it's a reckless behavior. Okay, until now we will just coach, we will not punish. Okay, but if it's reckless behavior, that's a conscious disregard of substantial and unjustifiable risk, so now we have to do a disciplinary action, remedial action, or a punitive action. We have to punish. Okay, managing the human errors, we were asked two questions. Did the employee make the correct behavioral choices in their task? Is the employee effectively managing his own performance shaping factors? If yes, then the only answer is to console the employee. Now the error happened to him. هو مش قاصد. Okay, it's a human error. تمام؟ هو took the good choice, the normal choice, the يعني it's not his intention to do that mistake. But for the at-risk behavior, it's a behavior choice driven by perception of consequences. Okay, as we said, what are the consequences? Now we will, according to the consequences happened, we will act with coaching, or we will act with punishment, and we will put it as a reckless behavior. Immediate and certain consequences are strong. Now we will act like a reckless behavior. It will be not just an at-risk behavior. But if it's delayed or uncertain consequences are weak, rules are generally weak. If that happens, we will act as an at-risk behavior, and then we will coach. It's management by changing perceptions of risk, managed by changing consequences, managed by adding forcing functions. And here is barriers to prevent non-compliance. Okay. Like here is an example of these behaviors. For human errors, you are driving in your car and you are preoccupied by other things. You're driving home and suddenly realize you never stopped at the stop sign near your home. Okay, now you are overwhelmed about many things, so you are human. Okay, you didn't do anything intentionally and you didn't harm anyone. But here, the at risk, you're running short on time and decide to drive faster to get to work. You're driving 75 miles per hour in a 65-mile-per-hour speed zone. Now that makes a risk on you and on others because you are taking a higher speed on the road. But if you decide to go faster and switch lanes frantically to move through traffic faster, now this is a reckless behavior. Okay, you're simply going to die or harm other people intentionally. It's a reckless behavior. Now, I'm expecting your participation because we are going to show some scenarios and expecting you to try to solve them with me, inshallah, together. Okay? Are we ready? ready ولا مش ready؟ أدخل في السيناريوز ولا لأ؟ أبدأ سيناريوز يا جماعة؟ يلا توكلنا على الله. يلا go ahead. Okay. احنا هنا عايزين identify what's the type of breach or duty في السلايدز دي. Identify what type of breach or duty each of these scenarios indicates. Is it a human error? Is it at risk or reckless behavior? And duty to produce an outcome, or is it a duty to follow a procedural rule, or is it a duty to avoid unjustifiable risk or harm? Here we are going to the scenario. An accountant working for a hospital is asked to give the lab manager a sense of how much budget they had left over at the end of the fiscal year. This extra budget would be transferred to the mobile medical office. An underfunded service is to support homeless people in the city. When year-end spending was announced, the lab had overspent roughly $25,000 based in part on the accountant who incorrectly failed to account for some supply purchases made by the lab. The lab manager was told in his performance review that he needed to maintain better control of his budget. Okay. I will give you a minute to read the scenario again and to think what type of error had happened here. Is it a human error from the accountant? Is it at risk? Or is it a reckless behavior from the accountant? Did he do it intentionally in the start? Did he do something intentionally? If yes, he did it intentionally, so he is reckless. Okay. Now I'm expecting some answers. Yes, well done. Oh, yes, 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 yes. Thank you all. On the accountant, yes. Here. Address on the lab manager part. But here it's the problem from the accountant. He is the one who incorrectly failed to account for some supply purchases. No, it's not the problem of the lab manager, it's the problem of the accountant. But yes, it's a human error because he didn't do that in purpose. No, he's not reckless. He needs some more training. He needs to console. We need to improve his performance. But yes, he had a human error. طيب in this scenario طبعا ما دام هو accountant يبقى human error. هندخل بقى في الدكاترة يبقى ايه؟ يبقى طبعا الدكتور ده لازم يعني يتعلق على باب زويلة. صح، هو ما عندوش ممارسة جيدة بالظبط كده ويلزم التدريب. أي نعم. So it's a human error and we have to console. Here is a doctor removing a cyst from the arm of a teenage boy. Decides to take a culture while the incision in the boy's arm is still open. To find a swab, the doctor opens a few drawers and cabinets. The doctor does this without removing his gloves or engaging in any hand hygiene between contacts with the incision. Is this duty to procedure to produce an outcome, or this is a duty to follow a procedural rule, or this is a duty to avoid causing unjustifiable risk or harm? Yes, I know this is a reckless act. Yes, I'm going ahead with you. But what duty of the three duties is breached here? Is it a duty of an outcome? Yes, thank you. Yes, thank you. It's a procedure. It's a duty to follow a procedural rule, and he didn't follow this duty. Yes, you're right. Thank you. Okay. We are going to the third scenario. Yes, this is the duty to follow a procedural rule. Now, the third scenario here, a surgeon drops an instrument on the floor in the operating room. Upset by the delay, the surgeon reaches down to the floor, picks up the dropped instrument, and then continues with the surgery using that same instrument. The scrub nurse looks at the surgeon, horrified by the significant breach in the sterile procedure. What kind of breach is this? Is it a human error, at risk, or drifting behavior, or a reckless behavior? Yes, I know that these scenarios are horrible. It's extreme, but they are put here just to clarify what we are talking about. Yes, yes. I think you're going to kill the doctor. I feel that too. You are right. Yes, this is definitely a reckless behavior, and I think it's not logic at all. But we are here using these scenarios to clarify what do we mean about a human error the at-risk behavior and the reckless behavior, and to be just like drawn in our heads. How different are these? Yes. Here's our next scenario. The intravenous pump of a patient starts to be signaling an occlusion in the intravenous line. Okay. A nursing assistant notices the alarm and alerts the nurse on duty. 30 minutes later, the nurse has still not come in to investigate the situation. The pump continues to beep, and the patient begins to hit the call light each time the alarm rings. He is afraid. Repeated attempts to get the nurse in the room are unsuccessful. Frustrated, the nurse assistant shuts the pump off to keep it from beeping and to keep the patient happy, because now it's turned off, the noisy pump, until the nurse can come and fix the problem. 45 minutes later, the nurse comes in the room, checks the IV, and notices that the catheter is unable to flush. Now we have to remove the catheter and insert another one. Investigation reveals that the nurse was watching a much anticipated television episode in the break room. Which kind of breach is this? Is this duty to produce an outcome, or duty to follow a procedural rule, or duty to avoid causing unjustifiable risk or harm? Okay. Okay. طيب احنا لو قلنا ان هي كانت مشغولة في عيان تاني بتعمل له مثلا، هي في السي بي ار تيم وكانت مشغولة في ان هي بتعمل سي بي ار في عيان تاني، وده اللي خلاها تتأخر 45 minutes. كان هيبقى ساعتها المشكلة مشكلتها هي ولا مشكلة سيستم؟ صحيح، كان ساعتها هتبقى مشكلة سيستم. فإحنا دلوقتي الخطأ اللي حصل هو نفس الخطأ، بس إحنا عشان كده بنقول إن إحنا بنحلل وبنعمل analysis عشان نعرف هو أصلاً إيه اللي حصل، فبناء عليه أقدر أحدد إيه البريتش اللي حصل. Is it a human error ولا at risk behavior ولا reckless behavior and what duty is breached. فلو نفس السيناريو حصل بالظبط بس هي كانت مبحوثة في حاجة تانية، ده معناه إن أنا عندي الستافينج بيرسونيل أقل من اللي مطلوب، يبقى ساعتها المشكلة طلعت من عندها خالص وبقت مشكلة سيستم. يبقى بدل ما أقول أصل هناء هي اللي غلطانة والأسلوب الأولاني اللي كنا بنتبعه بتاع البليم، أو إن كل حاجة أقول أصل العدد قليل، أصل مش عارفة إيه، فيبقى السيستم هو اللي فيه ايرور. يبقى إحنا هنا لما فهمنا يعني إيه just culture، قدرنا إن إحنا لما نشوف السيناريو ونشوف الأحداث حصلت ونشوف الانفستيجيشن أهي investigation revealed that إيه اللي حصل، إن الست هانم كانت قاعدة تتفرج على التلفزيون ابيسود في وقت البريك، في البريك روم، في وقت الدوام، يبقى ساعتها قدرنا نعرف إن ده is reckless behavior and the breach of the duty to avoid causing unjustifiable risk or harm. صحيح الهارم اللي حصل ان احنا ايه هنغير الكاتيتر، بس it's harm كان المفروض ان احنا نتجنبه. طيب اخر سيناريو، ايه ده ليه كده هو ده ايوه صح تمام duty to avoid causing unjustifiable risk or harm. آخر سيناريو وهنخلص المحاضرة إن شاء الله بعديه وهناخد بريك شوية إن شاء الله. A medication nurse at a nursing facility was caught borrowing medication from one resident to give to another. This occurred during the midnight shift, where the nursing facility did not have midnight pharmacy support. The medication nurse's patient had run out of a pre-ordered hard medication. To get the medication to the patient, the medication nurse pulled the medication from another resident's pre-packed medications. The medication nurse intended to replace the borrowed medication once pharmacy restocked the resident medications. Okay, we had an investigation. The investigation revealed that this medication nurse was taught the borrowing practice by a more experienced medication nurse. What type of breach is here? Is it a human error or at risk or drifting behavior or a reckless behavior? Thank you very much. Thank you very much. Okay, why do you think that it's a human error? Is it unintentional? Mr. Abdullah, is it unintentional or she did it intentionally? I think here it's very clear that she did that intentionally, as the scenario said, and that here here the other experienced nurse told her to do that. If you need something, borrow from other patient, and in the morning you can take from the yes, she didn't intentionally, so it's not a human error. That's what I want to say. No, it's an error. Okay, yes, I'm with you that it's a night shift and it's not no availability of the pharmacy, but still the doctor's orders has to be settled from the morning. If there's no pharmacy in the night, or it should be 24-hour or whatever. But now I'm not blaming the system, because the system is already there and done like that, and they know that there is no pharmacy in the night, so they had to prepare for that when the pharmacy is there. Okay, it's not an emergency medication asked by the doctor. No, it's not clear that here that it was an emergency medication. No, but she didn't stock her medications correctly, so that deficiency happened. So it's okay, no problem. We can take from the other patient's stock, and then we will put it in the morning. So it's intentional, and it didn't cause that harm to a patient. So it's still not a reckless behavior and not a human error. It's an at-risk behavior. Yes. It's drifting from our policies and from what expected from us to do. It's an at-risk. Just culture is a balance between the life, liberty, and happiness. That's the motivation. And on the other side, the harm, the rule, the outcome, our duty. So remember, staff are accountable for the quality of their choices and for reporting both their errors and system vulnerabilities. It's all about safety, shared accountability, and contents. Working together for our patients and one another makes our healthcare facility a great place to be. Thank you. Thank you for your active participation and for attending this lecture. And you made my day with your active participation. Thank you very much. Now, what about taking Allah يعافيك يا فندم. What about taking a small break, maybe 15 minutes, and come back to continue our fruitful day. Next lecture, we have some, it will be a little bit hard, but inshallah after that it will be so there will be more interaction in the next one. So just 15 minutes if that is possible with you. You have Maghrib now? No, we don't have for us now. Okay. Maybe at 6:30 inshallah we will continue, and after that I will take break also for Maghrib prayer and see you back inshallah. Thank you very much. Inshallah 6:30 I will be here. I will start. Okay? Oh, it will be too long for 6:45. Just give me 10 to 15 minutes. Okay? Thank you. Don't worry, it will be short. This fourth lecture, it will be very short. We will give it inshallah briefly. We will take break for salah inshallah and come back to continue the rest. السلام عليكم ورحمة الله وبركاته. شكرا جزيلا لانتظاركم. نبدأ بقى نكمل إن شاء الله. الليكتشر ديت هتبقى عن ال ESR. أي حد بيشتغل في مكان معتمد سباهي.
السلام عليكم دكتورة لميا.
وعليكم السلام ورحمة الله وبركاته. ازيك يا دكتورة هبة؟
الله يسعدك دكتورة لميا، بعد إذنك مش في بريك المغرب، صلاة المغرب، يعني ممكن من الساعة 7 ل 7:30 ناخد بريك صلاة.
أيوة إن شاء الله، ما أنا قلت لهم نخلص المحاضرة دي سريعا إن شاء الله وناخد بريك من 7 عشان يبقى
تمام
متوافق مع الجميع إن شاء الله.
تمام
عينيا
تمام،
حاضر.
شكرا لحضرتك
تمام.
يا دكتورة، الله يسعدك.
الاي اس ار ديت كلمه لما بنسمعها دايما اي مكان فيه سي يقول لك احنا عندنا اي اس ار. اي اس ار اي اس ار ده مين؟ ده الاسينشال سيفتي ريكويرمنتس. بتيجي السباهي تشيك على شويه ريكويرمنتس حفاظا على البيشنت سيفتي. مهمه جدا. الريكويرمنت اللي فيها يسقط يبقى كل سنه وانتم طيبين. غالبا المستشفى سقطت في كل حاجه، هو مش غالبا، هو ريكويرمنتس مانداتوري. السقوط فيها كارثه. مين السباهي؟ ده السعودي Central Board for Accreditation of Health Care Institutions، وهو من أقوى الاعتمادات. يعني فعلا قوي والrequirements بتاعته حلوة جدا ومهمة. يعني اللي واخد سباهي تأكد إن هو فعلا إن شاء الله مكان محترم. طيب ندخل على إيه ال ESR اللي اتكلمت عنهم السباهي. أول حاجة هنتكلم عنها الميديكيشن مانجمنت. طيب The hospital هو احنا اللي احنا هنتكلم، يعني الكلام دلوقتي ده مكتوب، ده عبارة عن requirements. يعني السباهي لما بتيجي هي مديانا الريكوايرمنتس دي بحيث ان هي تكون عندنا، وبتيجي تبدأ تتشيك، تشوف بقى الاكتيفيتي بيتعمل لا ولا لا، وايه الايفيدنس ان الاكتيفيتي ده بيتعمل. تمام. فاحنا هنقول هو ايه الريكوايرمنت اصلا. medication management requirement ان الهوسبيتال يبقى عندها system for the safety of high alert medication. high alert medications دي drugs that bear a highest risk of causing patient harm when used in error. زي الفيديو اللي كان الصوت بتاعه مش واضح كده، اللي هو ايه، في medication لو أنا استخدمته بالخطأ may lead to major problem to the patient. It may lead to death even. So it should not be there everywhere and reachable, and anyone can give it by mistake. The high alert medication should be stored في مكان مخصص لطريقة معينة for dispensation وهكذا، عشان أقلل الerror as much as possible for the patient safety. طيب. Errors may not be common with these than with other medications, but the consequences of errors may be devastating. It may even lead to death. Several worldwide organizations has identified a list of high alert medications such as the WHO and ISMP. Hospitals should have a plan for the safe use of these medications and develop their own annually updated list of high alert medications with the related safety strategies to minimize errors and harm from these medications and hazardous pharmaceutical chemicals as much as possible. ندخل على requirements اللي هي عملوها علشان ال high alert medications. measurement element. There is يعني إن يبقى المنشأة عندها there is a written multidisciplinary plan for managing high alert medications and hazardous pharmaceutical chemicals. It includes identification, location, labeling, storage, dispensing, and administration of high alert medications. الاكتيفيتي ده هنبص عليه فين؟ في الدوكيومنت ريفيو. الايفيدنس هنراجع البوليسي. يعني ايه؟ هم حاطين الميجرمنت element ده هو بيقول انا عايز يبقى عندك written multidisciplinary plan عشان المانجمنت بتاع الهاي اليرت ميديكيشن. طب هم لما هيجوا هيلاقوا ايه؟ هيلاقوا الريتن بلان. يبقى هم هيجوا يدوروا على ايه؟ على الدوكيمنت. يبقى احنا هنعمل دوكيمنت ريفيو. ايه الدليل بتاعنا؟ الايفيدنس ان احنا بنعمل بيه ولا لا؟ البوليسي موجوده ولا مش موجوده، والدوكيومنتس موجوده ولا مش موجوده، ويبداوا يبصوا على الهاي اليرت ميديكيشنز فعلا ستورد زي ما احنا كاتبين في البوليسي ولا لا، ومحطوط عليها ليبلنج ولا لا، وطريقه صرفها ماشي ازاي، وكل حاجه. اوكي، يبقى دي اول requirement. Then the hospital identifies an annually updated list of high alert medications and hazardous pharmaceutical chemicals based on its own data and national and international recognized organizations, زي Institute of Safe Medication Practice and the World Health Organization. The list contains, but is not limited to, the following. الليستة يبقى فيها ايه؟ controlled medications and narcotics, neuromuscular blockers, chemotherapeutic agents, concentrated electrolytes زي hypertonic sodium chloride and concentrated potassium salts, antithrombotic medications like heparin and warfarin, insulins, anesthetic medications زي propofol and ketamine. هيبصوا على ايه؟ هيعملوا document review. evidence ايه؟ a list of high alert medications and hazardous pharmaceutical chemicals, medications included in the hospital formula. طيب تاني حاجة، the hospital عندها system has a system for the safety of the look-alike and sound-alike medications. This is called LASA, look-alike and sound-alike medications. هو أصلاً العنوان ده لسه لا، العنوان ده هنا مش، معلش العنوان ده سابق. احنا لسه هنتكلم على لوك الايك السلايد اللي جايه. احنا لسه في الهاي اليرت ميديكيشنز. الريكوايرمنت هنا investigational drugs as applicable, other medications are as identified by the hospital. كل ده تبع الريكوايرمنت اللي فات. اوكي، كل ده قلنا هنلاقيه في البوليسي. الريكوايرمنت الثالث ان the hospital plan for managing high alert medications and hazardous pharmaceutical chemicals is implemented. This includes, but is not limited to, the following: improving access to information and about high alert medications, limiting access to high alert medications, using auxiliary labels or computerized alerts if available, standardizing the ordering, transcribing, preparation, dispensing, administration, and monitoring of high alert medications, employing independent double checks. كل ده الاكتيفيتي بيبقى بيتشاف ده بيتعمل ولا ما بيتعملش ازاي by observation and by staff interviews. Finally, the hospital develops and implements standard concentrations for all medications administered by intravenous infusion, and this is monitored by document review and staff interview. Okay, this is about the high alert medications requirements from CBH. Then now we are going to talk about the LASA. What is the LASA? Okay. The intent here, medication errors related to look alike and or sound alike medication names are common in the healthcare setting throughout the medication use process. Look-alike, sound-alike medications account for an estimated 25 to 30% of all medication errors. With tens of thousands of medications currently in the market, the potential for serious errors due to confusing medication names is significant. Contributing to this confusion are incomplete knowledge of drug names, newly available products, similar packaging or labeling, similar clinical use, eligible prescriptions, or misunderstanding during issuing of verbal orders. The worldwide organizations such as the WHO and ISMP had identified, published, and periodically updated several lists of LASA medications. The hospital shall initiate and annually update their own list of LASA medications names. The hospital should establish scientific-based safety strategies to prevent or minimize errors with such medications. هو في drugs مثلا زي مثلا أسيتازولاميد وأسيتوهكساميد. طيب يعني لما أقول لك مثلا في التليفون أسيتازولاميد ممكن you get that as acetohexamide. So this is sound alike, or sometimes مثلا لما يكون الدراج في الفارماسي نفسها وانا ببص كده بدور على الاسم ممكن it looks alike فاطلع حاجه مكان حاجه. صحيح، دوبامين and دوبيوتامين، تمام. ولهذا اتعملت الريكوايرمنتس دي عشان تقلل الريسك ان يطلع دواء مكان دواء ممكن يبقى completely different in action and sometimes ممكن يكونوا بيدوا actions اصلا عكس بعضيهم فتبقى disaster. So في بعض الطرق اللي بتستخدم في الصيدلية مثلا علشان أفرق شكل الدواء ده عن ده، وأحيانا كمان مش بس في الصيدلية، أحيانا على السيستم. يعني ممكن أنا كميديكال دكتور ببريسكرايب medication on the system، كتبت مثلا أول كام حرف فطلع لي الدواء، جيت دايسة عليه كليك وقلت أيوه هو ده، but it's a look-alike، it's different from اللي أنا عايزه أصلا. فاصلا الفارماسيست مش هيعرف ان انا ما كانش قصدي ان انا اكتب الدواء ده. عشان كده في شويه طرق تقلل نسبه حدوث الخطا ده. من ضمنها مثلا ان انا لما اكون بكتب في حاجه اسمها تولمان letters، اجي كده على بعض الحروف في الدواء واكتبها كلها capital letters. زي ما كنت بقول مثلا الاسيتا زولاميد، اجي على كلمه زولاميد واكتبها كلها كابيتال. واسيتو هيكساميد اكتب الهيكساميد كلها كابيتال. ان انا اول ما عيني هتيجي عليه هشوف كلمه هيكساميد يبقى ده الاسيد هيكساميد مش الزولاميد. اوكي. دي طريقه علشان اقلل بيها الهيومن ايرور، ان انا ممكن عيني تخلف واجيب حاجه مكان حاجه. اوكي. طيب ال requirements هنا هنبدأ نتكلم عليها. There is a multidisciplinary policy and procedure on handling look-alike, sound-alike medications. يعني ال requirement أصلا إن يكون أصلا في policy أو procedure. تمام؟ طب هم هيجوا يدوروا على إيه؟ document review. يبقى هيجوا يدوروا على البوليسي موجودة ولا مش موجودة. تاني حاجة the hospital reviews and revises annually its list of confusing drug names, which include LASA medication names, pairs, the hospital stores, dispenses, and administers. ده برضو بيبقى document review وبيشيكوا إن الدوكيمنت بتاعتك متطرخ ومتطرخ جديد وإن هو بيتعمل له annual update. The hospital takes actions to prevent errors involving LASA medications, including the following as applicable. A. Providing education on LASA medications to healthcare professionals at orientation and as part of continuing education. The second is using both the brand and generic names for prescribing LASA medications. Then writing the diagnosis أو indication of the LASA medication on the prescription. زي ما كنت بقول من شوية، طب افرض إن أنا كطبيب أنا اللي اتلخبطت وتشيكت another، يعني عملت check على another medicine that's a LASA, so the pharmacist will not know. لا، هنا the pharmacist will know if the. علشان كده كل السيستمز الجديدة بتلاقي فيها إن أنت بتكتب الميديكيشن وبتكتب الدايجنوزس مع كل ميديكيشن، علشان اللي هيجي يصرف الدواء هيبقى واخد باله حضرتك كاتب دايجنوزس ايه للدواء ده. لما يلاقي الدايجنوزس مش ماشي مع الدواء يبقى غالبا حضرتك كتبت الميديكيشن باي ميستيك، فهيرجع لك ويسألك لا يكون لاسا. Changing the appearance of look-alike product package. يعني مش لازم ان الاتنين يكونوا نفس الشكل فانا اتلخبط، يبقى ممكن نغير الابيرنس بتاع الميديكيشن نفسه، الباكجينج بتاعه. Reading carefully the label each time a medication is accessed and or prior to administration. عايزين يبقى فيه كذا تشيك مع الصرف، تشيك مع قبل ما ادي الدواء، تشيك وهكذا. Minimizing the use of verbal and telephone orders. اي حرف يتنطق بصوره اسمعها غلط ادي كده انا اديت دواء غلط. ف as much as possible بلاش prescriptions بالتليفون بالصوت كده. Checking the purpose او indication of the medication on the prescription prior to dispensing and administering. زي ما قلنا خلاص انا كاتب الdiagnosis والpharmacist هيتشيك يتأكد إن الدياجنوسيس ماشي مع الميديكيشن. Placing LASA medications in locations separate from each other or in non-alphabetical order. مش لازم يبقوا ماشيين بنفس الالفابيتيكال اوردر فعيني تخلف، لا حط ده في حتة وحط ده في حتة. طيب ده احنا هنعرف ان كنتوا ماشيين على ال requirements دي ولا لا ازاي؟ by observation, by document evidence, and by staff interviews. A review بيبقى فيه evidence of adequate number of staff receiving educational material and attendance. Staff interview and observation, the evidence of error prevention strategies due to LASA and mandatory competences for nurses, doctors, and pharmacists. Every 2 years record for LASA medications and attendance records. المحاضرات اتعملت وفي attendance والريكورد موجود وكل ده بيبقى surveyed by the سباهي surveyor. طيب النقطة الثالثة المهمة في ال ESR, the hospital has a process for monitoring, identifying, and reporting significant medication errors, including near miss, hazardous conditions, and at-risk behaviors that have the potential to cause patient harm. What's the intent of this? Medication errors compromise patient confidence in healthcare system and increase the costs of healthcare provision. Some medication errors result in serious harm and results in increased patient morbidity and mortality. The fundamental purpose of medication error reporting system is to learn how to improve the medication use and prevent errors reoccurrence. Medication errors are probably undetected and underreported. Reporting of medication errors must become culturally accepted throughout the healthcare system. A major investment of resources will be required in the healthcare system to apply the lessons learned from the reporting of medication errors. Medication error reporting system should include near miss, hazardous conditions, and at-risk behaviors. ايه الهيصة دي؟ دلوقتي احنا ده مثال على الكالتشر اللي احنا عمالين ندعو اليها، اللي هي blameless culture، اللي هي بتحفز على الريبورتنج، ان لو حصل medication error ان احنا نعمل له ريبورتنج، وكمان مش بس هنعمل ريبورتنج، ده احنا هنقول اللي حصل كان نير مس ولا حصل sentinel event بناء على الميديكيشن ايرور ده. طب احنا ليه بنعمل كده؟ احنا علشان نتجنب ان يحصل البروبلمز دي تاني وانها تتكرر. انا عايزه اعمل تحليل الميديكيشن ايرور ده حصل ليه؟ هل هو بسبب مثلا ليسا؟ هل هو كان في اسم مشابه ليه فاتصرف بالغلط؟ ولا هو ما كانش ليبلد كويس؟ ولا هو ايه اللي حصل؟ اوكي؟ وادى لايه؟ طيب انا هستفيد ايه؟ ما هو اصل هو ممكن كان حصل serious harm او ادى الى morbidity ومورتاليتي، فده كلف الهيلث كير سيستم تكلفه اضافيه عشان نصلح اللي حصل من الغلط اللي حصل. وكمان انا كبيشنت لما تديني مش عارفه ايه بدل ايه، انا اصلا لا هثق فيك كدكتور ولا هثق فيكي كمنشأة ولا هثق في الممرض ولا في الفارماسيست. So medication errors are very important to keep the الثقة ما بين البيشنت، الconfidence ما بين البيشنت and the healthcare system, and to save the lives and keep the patient safe in your facility. So they have these requirements. There is a multidisciplinary policy. كل حاجة هتلاقي أولها إن إحنا في policy موجودة ولا مش موجودة، البروسيجرز موجودة ولا مش موجودة، هيجوا يسألوا على إيه؟ على الدوكيومنت، هي فين البوليسي، وهيعملوا لها ريفيجن. إن في multidisciplinary policy and procedure on handling medication error, near misses, and hazardous situations like confusion, overlook, alike, sound alike drugs and similar packaging. تاني حاجة the policy فيها clear and acceptable definition of significant medication errors, near misses and hazardous situations. The treating physician is notified of the medication error at the appropriate time. طب ده أنا هعرف إزاي إن كان ده بيحصل ولا ما بيحصلش؟ بالstaff interview. الإيفيدنس هو timeliness of reporting. بلف كده وأقول لهم حضرتك لما بيحصل medication error أنت بيبلغوك؟ طب بيبلغوك بعدها بقد إيه؟ إيه ده؟ لا ده أنا معرفتش غير تاني يوم وأنا بمر على العيان. يبقى مفيش هنا timeliness reporting. طب إيه الفكرة في timeliness reporting؟ أولاً إن هو يعرف إن كان ده contra indicated ولا لأ، إن كان في action ممكن أعمله علشان correct this error دلوقتي وما يحصلش harm للبيشنت ولا لأ. يعني it has to be he has to be informed immediately. طيب إيه كمان؟ medication error reporting is completed within the specified time frame after discovery of the error. ده برضو هعرفه by the staff interview. And the hospital has a standard format for reporting medication errors. طبعا ده بنراجع documents وبلاقي إن في عندي form for medication error reporting. Staff are educated on the process and importance of medication error reporting. هعرفها ازاي؟ بالstaff interview. هسأل الستاف انتوا عندكم طريقة للميديكيشن ايرور ريبورتنج ولا لأ؟ هيبدأ يبان في لو حصل كذا بنريبورت في كذا وعندنا الريبورت اهو وهكذا. ف بعرف ان فعلا البروسيس انا رجعت الدوكيومنتس بس عايزه اعرف البروسيس is really on track ولا لا، بتحصل ولا ما بتحصلش. That's the rule of the staff interview. There is active reporting of medication errors, near misses and hazardous situations. براجع documents. And the hospital conducts intensive root cause analysis for all significant or potentially significant medication errors. ده برضو بشوفه بالdocument reviews. بنشوف الريفيو بتاع الروت كوز اناليسيس المعمول ايه. هنتكلم على الروت كوز اناليسيس ده محاضرة كاملة ان شاء الله، هتبقى لطيفة. طيب the next requirement is the medication error, near miss and hazardous situations are documented in the patient's medical records. فده هيحتاج ان السيرفيرز يراجع open medical records، يفتح الميديكال ريكوردز ويعمل لها medical record review. ل selected cases هيراجع reported medication errors. طيب الستاندرد الثانية the hospital utilizes reported data to improve the medication use process and prevent medication errors and improve patient safety. هنعرف ازاي المستشفى بتعمل كده ولا لا؟ هنراجع الدوكيومنتس. الفارماسي and therapeutics committee interview. هنعمل انترفيو مع التيم بتاع الفارماسي and therapeutic committee. هراجع الميتنج مانتس بتاعتهم، هشوف الاناليسز بتاعهم للايفنتس وايه الكوركتيف اكشن بلان. ده هيبقى بروف ان المستشفى دي فعلا بتجمع داتا وبتريبورت الداتا دي وبتطلع منها ازاي اعمل امبروفمنت للبروسيس بتاعه الميديكيشن يوز. الهيلث كير اللي بعده healthcare professionals are provided with feedback on reported medication errors, near misses and hazardous situations. في الآخر الهيلث كير بروفيشنال عرف النتائج ولا لأ، ده بنعرفه بالستاف انترفيو. بيعملوا انترفيو للستاف إن هم have reported medication errors and receive feedback accordingly or unit feedback. Finally, the hospital reports sentinel events related to serious medication errors to the relevant authorities, and this is also by document review. Evidence of reporting sentinel events related to serious medication errors to the relevant authorities. Interview of members of the pharmacy and therapeutic committee on the process of reporting sentinel events. طيب أنا عارفة إن دي محاضرة يعني تقيلة شوية لأن كلها requirements، بس they are really very important requirements and these requirements if not met simply المنشأة هتسقط سباحي. تمام. for now احنا خلصنا المحاضرة كده سريعا زي ما اتفقنا في نصاية علشان كلنا ناخد البريك بتاعت صلاة المغرب. غالبا هيكون المغرب كده خلاص أذن في كل حتة، نصلي المغرب إن شاء الله 10 دقايق ونلتقي نكمل إن شاء الله.
دكتورة لميا بعد إذن حضرتك 7:30 بإذن الله ممكن نبدأ؟
حاضر اللي حضرتك تحبيه حسب السكيدول بتاعته، تحت أمرك.
طيب الله يسعدك، من 7 ل7:30 إن شاء الله البريك.
خلاص تمام على خير إن شاء الله، يبقى 7:30 نتقابل إن شاء
شكرا
الله.
دكتورة.
المحاضرة الجاية عن الريسك مانجمنت بأمر الله. شكرا يا جماعة على
شكرا
حسن استماعكم،
شكرا
ورب
دكتورة.
ما يكون عليكم يعني يا رب.
إن شاء الله يا جماعة البريك هيكون من 7 ل7:30. شكرا.
الدكتورة راغدة كانت بتسأل الاعتماد بيتجدد؟ طبعا احنا ما فيش حاجة عندنا بتحصل إلا لما تتجدد، لأن أنا لازم أتأكد إن البروسيس مش بس اتعملت وهي قائمة، لا هي قائمة وموجودة وما زال الناس ماشية على الريكويرمنتس دي. فمش هديها لك كده for granted، مش انت نجحت وكل سنة وانت طيب، لا انت نجحت وهطمن عليك every now and then ان هي البروسيس دي ماشية عند حضرتك وان انت ماشي على requirements. يس بتتجدد.
دكتورة لميا بعد إذنك هنخلص الساعة كام النهاردة إن شاء الله؟ يعني بعد ما نرجع من البريك 7:30 هنخلص الساعة كام؟
هو
عشان في ناس
غالبا
بتسأل.
ان شاء الله على 10 زي السكيدول، لان المحاضرتين الجايين تقال شوية وفيهم شرح. واحدة فيها برضو requirements والتانية هتبقى ظريفة ولطيفة وهتعدي حلوة يعني، بس يعني على 9:30 مش قبل 9:30.
إن شاء الله يا دكتورة ربنا يخليكي.
In English, now we have a break till 7:30 inshallah. After 7:30 we will start the next lecture about risk management inshallah. Yes, you're welcome, Mona Lisa.
السلام عليكم. بالنسبة لسؤال الأخت شيخة إن متى ما التواصل معاها أبدا، طب إزاي حضرتي الزوم النهاردة يا أخت شيخة؟ أكيد جالك الزوم. دي أول نقطة. النقطة التانية، إحنا بعتنا لك دلوقتي على العام من صديقتك. أوكي، إحنا بعتنا لك دلوقتي على العام رابط الحضور، برسله لك أهو حالا تاني. دقيقة واحدة أشوف لك رابط الحضور، ثواني. مفيش مشكلة، هبعت لك رابط الحضور وتدخلي اعملي بس الحضور النهارده. اوكي، النهارده وبكره، طالما حضرتي يومين بيتحسب لك الحضور. هنرجع اخت نورة الساعة 7:30 ان شاء الله. اي استفسار تاني، اي سؤال؟ دكتورة حنان بعد اذنك، بعتنا دلوقتي رابط الحضور، يا ريت النهارده وبكره تسجلي حضور بعد اذنك. تمام، بكره ان شاء الله هيكون موعد الساعة 4. الساعات بإذن الله هتنزل خلال 5 أيام إن شاء الله. مفيش أي مشكلة، ادخلي بس رابط الحضور، بس اكتبي اسمك انتي. طيب الاسم، ايوه الاسم ورقم التصنيف في رابط الحضور النهارده وبكره ان شاء الله. ايوه يوميا، لازم تسجلوا في رابط الحضور يوميا. لا الاسم مهم، لازم اسمك ورقم التصنيف في رابط الحضور، هبعتهولك حالا. الساعات هتنزل يا اختي لينا ان شاء الله خلال من 3 ل5 ايام ان شاء الله باذن الله. الرابط الحضور مش على الايميل، رابط الحضور هنا على الزوم. استاذه فاطمه هبعت لك رابط الحضور دلوقتي وسجلي فيه بعد اذنك، اللي موجود على الشات. لازم تسجلي فيه النهارده وبكره، مفيش اي مشكله، المهم النهارده وبكره. ايوه يا دكتوره ريهام، نفس رابط امس. يا ريت كلكم دلوقتي تسجلوا رابط الحضور بعد اذنكم. ايوه يا استاذ سامر، مفيش اختبار، كلامك مظبوط. ايوه يا استاذه حياه، سجلي الحضور يوميا، النهارده وبكره كمان. نفس الرابط يا اخت امل، نفس الرابط. البريك لغايه الساعه 7:30 ان شاء الله. استاذ ابراهيم، عايز جواب على ايه؟ معلش سؤالك مش واضح. انت حضرتك خلاص سجلت اليوم اكيد؟ سجل النهارده وبكره برابط التحضير. الساعات بتنزل خلال 5 أيام إن شاء الله بإذن الله. ما فيش مشكلة يا دكتورة حنان، لو نسيتي أمس المهم تسجلي النهاردة وبكرة إن شاء الله. أيوة، التحضير مرة واحدة بس في اليوم، مرة واحدة. أستاذ إبراهيم، إحنا بنسجل على طول مباشرة إن شاء الله ساعاتكم في السيستم عندنا في المنصة، ولكن بتكون إجراءات حسب الهيئة السعودية مش من عندنا، إن ده سيستم. المحاضرة الدكتورة تدخل الساعة 7:30، هنبدأ المحاضرة الثانية لغاية الساعة 10 على كلام الدكتورة لميا. حتى لو قطع النت عندك لا عادي، ما تسجليش تاني. أهلا وسهلا بكم. الله يعافيك يا رب. آمين وإياك يا أستاذ إبراهيم. حاولي يا أستاذة لميا. سلمى، ادخلي تاني على الرابط، هبعتهولك دلوقتي حالا. حضراتكم كمان عشان لما نخلص المحاضرات بإذن الله في رابط الواتساب تقدروا تدخلوا فيه برضو. المحاضرات النهاردة على كلام دكتورة لميا إن شاء الله تخلص الساعة 10، ممكن قبل 10 بس إن شاء الله الساعة 10 هتخلص. اللي ما سجل حضور أمس يقدر يسجل حضور النهاردة وبكرة بعد إذنكم. الله يعافيك يا دكتورة حنان، أهلا وسهلا بيكي. أستاذ بدر، بكرة إن شاء الله أول ما نبدأ المحاضرة الساعة 4 بنرسل تاني رابط الحضور سجل فيه، مش من النهاردة. احنا اتفقنا يا جماعة الدورة لسه ما خلصت. طيب لسه البريك، والدكتورة هتدخل دلوقتي وتكمل المحاضرات إن شاء الله.
السلام عليكم ورحمة الله وبركاته. Welcome back. قلنا كده just in time 7:30. نبدأ بقى إن شاء الله. تمام. In this lecture, we are going to talk about and discuss risk management. What's risk management? In this lecture, we will concentrate on the standards from the JCI, the seventh edition, talking about the risk management. What are the requirements of the JCI for us to search for if we are taking the requirements of the risk management in our facility or not, and how to prove that we are going on this requirements rules. هو الأول يعني إيه ريسك مانجمنت؟ يعني هيعمل لنا إيه الريسك مانجمنت؟ هستفيد منه إيه؟ هشير معاكم كده فيديو صغنن، ما هوش ساينتفك ولا أي حاجة خالص، بس هو بيورينا من الحياة how to apply risk management and what's the importance of the risk management in our lives. Let's check this together. This is, in short, what do we mean by risk management and why it's important and why it's critical and why the risk analysis is very important And the evaluation and re-evaluation is very, very important in our facilities because these are lives. We are dealing with lives. So let's start our talk about the risk management standards. Yes. The contents. Core components of risk management. The risk management program, the proactive analysis exercise, the culture of safety, the incident reporting, adverse and near-miss events, sentinel events, risky processes, monitoring and analysis. We're going to illustrate every point of these now, inshallah. The areas for risk assessment, infection control, medications, clinical alarms, suicide, information security, laboratory safety, staff health and safety, and facility management program. We will discuss every point in details now, inshallah. Risk management program. In the start, we'll talk about the structure and functions. Here is the requirements from the GCI as we talked in the first. An ongoing program of risk management is used to identify and proactively, is very important this word, proactively reduce unanticipated adverse events and other safety risks to patients and staff. Like we saw Tom, he proactively made the risk analysis and then continues his job, his work. That's what we are going to do, okay? In this standard, we will find that the hospital's risk management framework should include the risk identification, the risk prioritization, the risk reporting, the scope, objectives, and criteria for assessing risk management to include risk analysis and the management of related claims. Then, hospital leadership identifies and prioritizes the potential risks that could have the greatest impact on patients and staff safety and on the quality of patient care. Even in the start, we put the framework, and the framework should have risk identification and prioritization and reporting and that. Then the leadership should choose from these يعني نعمل لهم ايه prioritization علشان نختار ايه اكتر حاجة will have the greatest impact on our patients and staff safety. Then high risk processes are redesigned and implemented based on the results of the analysis of the risk reduction exercise. The second thing is the program initiation. We started by the structure and functions. Then we are going to the program integration. The quality and patient safety program provides for the integration of event reporting systems, safety culture measures, and others to facilitate integrated solutions and improvements. The third thing in the program is the program reporting. Hospital leadership develops and implements communication strategies to staff, governance, and the stakeholders as appropriate. The governing entity approves the hospital program for quality and patient safety and regularly receives and acts on reports of the quality and patient safety program. Then, the governing entity at least quarterly receives and acts on reports of the quality and patient safety programs, including reports and adverse and sentinel events. Then, hospital leadership communicates quality improvement and patient safety information to the governing entity and hospital staff on a regular basis. The hospital leadership reports to the governing entity include at least quarterly, include what? Include the number and type of sentinel events and what were the root causes, whether the patients and families were informed of the sentinel events or not, what are the actions taken to improve safety in response to sentinel events, and if the improvements were sustained. That was our first step. The first step is the risk management program. Okay, we had made the risk management program. Now we are going to the proactive analysis exercise. We said that this is an ongoing program of risk management. Is used to identify. Now we completed the identify and proactively reduce unanticipated adverse events and other safety risks to patients and staff. Now we are here in the proactive analysis. At least annually, a proactive risk reduction exercise is conducted on at least one of the priority risk processes. There are multiple tools that can provide a proactive analysis of the consequences of an event that could occur in a critical high-risk processes. For example, the failure mode and effect analysis and the hazard vulnerability analysis. Then we are going to the culture of safety. Here a requirement for the hospital leadership creates and supports a culture of safety program throughout the hospital. How? Hospital leadership establishes and supports an organizational culture that promotes accountability and transparency. Do you remember what we called the lecture about the just culture? Yes, here. Hospital leadership develops and documents a code of conduct and identifies and corrects behaviors that are unacceptable. Hospital leadership provides education and information, such as literature and advisories relevant to the hospital's culture of safety to all individuals who work in the hospital. Hospital leadership defines how issues related to a culture of safety within the hospital are identified and managed. Then, hospital leadership provides resources to promote and support culture of safety within the hospital. Then, hospital leadership provides a simple, accessible, and confidential system for reporting issues relevant to a culture of safety in the hospital. Hospital leadership ensures that all reports related to the hospital's culture of safety are investigated in a timely manner. The hospital identifies systems issues that led healthcare practitioners to engage in unsafe behaviors. Then the hospital leadership uses measures to evaluate and monitor the safety culture within the hospital and implements improvements identified from measurement and evaluation. مفيش جودة في الكوكب without measurement and evaluation. ان احنا نحط standards في اي حته ونقول اصل احنا المفروض بنعمل كذا وكذا وكذا او المفروض نعمل كذا وكذا وكذا من غير ما يكون في measurement, this is a mess. It has to be measured and evaluated, and improvement projects are done upon these data, and we recollect data and we measure the control. Hospital leadership implements a process to prevent retribution against individuals who report issues related to the culture of safety. عايزين نضمن إن فعلا في good reporting and there is a just culture. Then we are going to the fourth part, the incident reporting, the OVR. Hospitals can follow many ways in reporting and receiving incidents. Some hospitals keeps the whole responsibility and control for risk management units. Others keep medication errors and adverse drug events with the pharmacy. Some keep the laboratory and infection control separate. Others assign different channels for reportable events through incident reporting, complaints, ethical dilemmas form, adverse drug events, medication errors form. Anyway, select what fits your case to cover the following standards. المهم انت اعمل اللي انت عايزه. عايز تبقى مع الريسك مانجمنت هم اللي يعملوا الفارماسي هي اللي تمسك الميديكيشن ايرورز والادفيرس اوكي whatever. المهم عندي ان انا في الاخر اكون مغطي ال following standards for the incident reporting اللي هم ايه؟ The hospital's risk management framework includes risk reporting. Again, we're going to say this word again and again. Reporting. Without reporting, how can we know what's wrong is in our process and how to avoid getting in that mistake again? Reporting is the key word today. The hospital uses a defined process for identifying and managing adverse, no harm, and near-miss events. Hospital leadership has a mechanism for blame-free reporting of adverse events, no harm events, and near-miss events. Then, hospital leadership implements, monitors, and takes action to improve the program for a culture of safety throughout the hospital. The hospital leadership provides a simple, accessible, and confidential system for reporting issues relevant to a culture of safety in the hospital. Again, in the incident reporting, here the hospital's framework for ethical management addresses ethical issues and decision-making in critical care. The hospital's framework for ethical management establishes a mechanism by which the hospital care practitioners and other staff may raise ethical concerns without fear of retribution. Framework for ethical management, the hospital operates within this framework to establish a mechanism by which healthcare practitioners and other staff may report clinical errors and raise ethical concerns with impunity, including disruptive staff behavior related to clinical and/or operational issues. We need to explain here some examples of standards requiring reporting or process for reporting or related to reporting. Medication effects on patients are monitored. The hospital utilizes a standardized process for reporting adverse medication effects as part of the hospital quality program. This is a requirement for the GCI. In the previous lecture, we talked about the requirements from the SIBAHI, and here, the same. The hospital establishes and implements a process for reporting and acting on medication errors and near misses or close calls. All these things, we are going to talk about with some illustration in the next lecture, inshallah. The hospital establishes and implements a process for reporting and acting on medication errors and near misses. Then the facility maintenance here is talking the hospital's program for the management of hazardous material and waste includes the inventory, handling, storage, and use of hazardous material. The hazardous materials and waste program establishes and implements procedures for the management of spills and exposures, including the use of proper protective equipment and reporting of spills and exposures. The hospital has a process to protect patients and staff from blood-borne pathogens related to exposure to blood and body fluids. The hospital utilizes a process for reporting patients and staff exposures to blood and body fluids. The hospital has a process for monitoring and acting on medical equipment hazard notices, recalls, reportable incidents, problems, and failures. The hospital reports any deaths, serious injuries, or illnesses that are a result of medical equipment through the hospital's incident and adverse event reporting process. Finally, surgical care that includes the implanting of a medical device is planned with special consideration of how standard processes and procedures must be modified. Policies and practices include the reporting process for implantable device-related adverse events. What about the adverse and near-miss events? Definitions. The hospital uses a defined process for identifying and managing adverse, no harm, near-miss events. Hospital leadership establishes a definition of adverse events, no harm events, and near-miss as defined in the intent. Here, an adverse event, a patient safety event that resulted in harm to the patient. في harm حصل. Then it's an adverse event. Adverse event. The harm already occurred to the patient. The harm reached the patient. A no harm event. The patient safety event that reached the patient but does not cause harm. But it really reached the patient. Here, the difference between the adverse event and the no harm event, both events reached the patient. But in the adverse event, it harmed the patient. But in the no harm event, it did not cause harm to the patient. What about the near miss? The near miss or the close call, a patient safety event did not reach the patient. It did not reach the patient. There is a mistake happened, but it did not reach the patient. But if we didn't control it before reaching the patient, It would be either no harm or an adverse event. A hazardous condition or unsafe condition, a circumstance other than a patient's own disease process or condition that increases the probability of an adverse event. Like what? Like the extrinsic factors we talked about in the reducing the fall harm for the patients. We said there are external factors, extrinsic factors, and intrinsic factors. Here, the hazards or the extrinsic factors are the that meant from here. Okay. After definitions, we are going to the next step is analyzing and managing adverse and near-miss events. The hospital uses a defined process for identifying and managing adverse and no harm and near-miss events. Hospital leadership defines a process for managing adverse events that includes analysis of the event to identify corrective actions. يبقى أول حاجة analysis. Hospital leadership defines a process for managing near-miss events and no harm events that includes an analysis of the events to identify corrective actions. Then the hospital leaders implement corrective actions. عملنا analysis, اتفقنا على corrective actions, then implementation when appropriate on the results of the analysis. طب ايه الضمان ان ال implemented corrective actions will really correct the problem? Now we are going to monitor the implemented corrective actions for potential process failures, unintended consequences, effectiveness, and sustainability over time. Examples of standards requiring acting on reporting events. Reported events, sorry. All equipment used for laboratory testing is regularly inspected, maintained, and calibrated, and appropriate records are maintained for these activities. The hospital has a system in place for monitoring and acting on laboratory equipment, hazard notices, records, recalls, reportable incidents, problems, and failures. Then, all equipment used to conduct radiology and diagnostic imaging studies is regularly inspected, maintained, and calibrated, and appropriate records are maintained for these activities. The hospital also has a system in place for monitoring and acting on radiology equipment, hazard notices, recalls, reportable incidents, problems, and failures. The hospital has a process to identify patients at risk for suicide and self-harm. The hospital monitors implementation and effectiveness of protocols and procedures for the prevention of patient suicide and or self-harm by analyzing data regarding self-harm, the incidents, or deaths. Adverse events resulting from the use of lasers and other optical radiation devices are reported, and action plans to prevent recurrence are implemented and monitored. When adverse events result from the use of lasers and or optical radiation devices, the adverse events are reported where action plans are identified and implemented to prevent recurrence. The hospital establishes and implements a process for reporting and acting on medication errors and near misses. The hospital establishes and implements a process for reporting and acting on medication errors and near misses, and uses medication errors and near miss reporting information to improve medication use processes. The hospital has a process for monitoring and acting on medical equipment hazard notices, recalled reportable incidents, problems, and failures. And then the hospital has a process for monitoring and acting on medical equipment and Implantable device hazard notices record reportable incidents, problems, and failures. The hospital develops and implements a process for handover communication. Data from adverse events resulting from handover communication are tracked and used to identify ways in which handover can be improved and improvements are implemented. The hospital identifies and implements a process for managing the reuse of single-use devices consistent with regional and local laws and regulations, and implements a process for managing expired supplies. When adverse events resulting from reuse of single-use devices occur, patients using these devices are tracked and an analysis performed, with results used to identify and implement improvements. Finally, the hospital has a process to protect patients and staff from blood-borne pathogens, as we talked, related to exposure to blood and body fluids. The hospital utilizes a process for acting upon patient and staff exposures to blood and body fluid. The hospital tracks and monitors incidents of patients and staff exposures to blood and body fluids. Reports of exposure incidents are reviewed and actions are taken to minimize the risk of future exposures to blood and body fluids. Now we talked about the standards for the analysis and management of the adverse and near-miss events. Now we are going to the sentinel events. What's the difference between sentinel events and adverse and near misses? The hospital uses a defined process for identifying and managing sentinel events. The hospital leadership establishes a definition of a sentinel event that includes at least thorough, found in the intent. What are the definitions of the sentinel events? Sentinel events should include at least one of these: a death. An event, when occurred, led to the death of a patient or a staff member is not just an adverse event, it's a sentinel event. Sentinel event may cause death or permanent harm, severe temporary harm, suicide of any patient receiving care, treatment, and services in a staffed around the clock care setting or within 72 hours of discharge, including from the hospital's emergency department, unanticipated death of a full-term infant, discharge of an infant to the wrong family, abduction of any patient receiving care, treatment, and services, any elopement, that's unauthorized departure of a patient from a staff around the clock care setting, including the ED, leading to death, permanent harm, or severe temporary harm to the patient. Hemolytic transfusion led to harm, transfusion reaction involving administration of blood or blood products having major blood group incompatibility. مش الماينر، لا الميجر هو اللي يعتبر sentinel event. Rape, assault leading to death, permanent harm or severe temporary harm, or homicide of any patient receiving care, treatment, and service while on site at the hospital. Rape, assault leading to death, permanent harm, severe temporary harm, or homicide of staff member. هنا كنا بنتكلم على patient receiving care، هنا staff member أو licensed independent practitioner أو visitor or vendor when on site at the hospital. Invasive procedure including surgery on the wrong patient. Now we're back again to the first lecture about ensuring safe surgery. Wrong patient, wrong site, or wrong procedure. This is a sentinel event. كان داخل يعمل cholecystectomy، عمل appendectomy. Unintended retention of a foreign object in a patient after an adverse procedure, including surgery. Severe neonatal hyperbilirubinemia above 30, bilirubin above 30. Prolonged fluoroscopy with cumulative dose more than 1,500 rads to a single field, or any delivery of radiotherapy to the wrong body region, or more than 25% above the planned radiotherapy dose. Fire, flame, or unanticipated smoke, heat, or flashes occurring during an episode of patient care. Any intrapartum maternal death related to the birth process. Finally, severe maternal morbidity, not primarily related to the natural course of the patient's illness or underlying condition, when it reaches a patient and results in a permanent harm or severe temporary harm. These are the areas of the sentinel events. What if a sentinel event occurred? How shall we go through? We shall go to the root cause analysis, and the root cause analysis is our next lecture's topic and last lecture topic, inshallah. The hospital uses a defined process for identifying and managing sentinel events. Here is the requirement that we have a process. We know it all, the stuff in the hospital, what to do if we have a sentinel events, how to identify and how to manage sentinel events. Hospital leaders complete credible and thorough comprehensive systematic analysis, for example, root cause analysis of all sentinel events within a time period specified by hospital leadership that does not exceed 45 days from the date of the event or when made aware of the event. Then the root cause analysis identifies all system and process origins that may have contributed to the event. Hospital leadership considers each identified contributing factor and takes corrective actions for improvement to prevent and reduce the risk of adverse events. Then, again, we will monitor the implemented corrective actions for potential process failures, effectiveness, and sustainability over time. Okay? Risky processes, monitoring, and analysis. Processes that pose patient safety risk are identified and monitored. Data collection should be sufficient to detect trends and patterns. Intense analysis of data takes place when adverse levels, patterns, or trends occur. For any process, we collect data related to this process. When we collect data and put it on whatever graphs or some things to analyze these data, we can notice that there is a trend or there is a adverse event or whatever, and upon this we're going to take an action. The actions for trends or unusual things in the process, it's either improvements. We should seek for improvement of the process, and then improvement طبعا needs analysis and whatever, blah blah blah, and then we choose the improvement in the same process and try to apply it, and we collect data again and then control, and we watch if the improvement did occur or not. Okay, or if we found that there is an adverse level and there is a problem that cannot be improved in the process, we change the whole process and go for planning again for a new process. Okay, and again measure the data and collect the data and measure and do the control measures and assess, is this process, is this new process is functioning well or needs improvement. Risky processes monitoring and analysis. Data are always analyzed when undesirable trends and variation are evident from the data. Data gathering and analysis are performed on what? On all confirmed transfusion reactions, if applicable to the hospital. Data collection is performed and analysis is performed on all serious adverse drug events, all significant medication errors, all major discrepancies between preoperative and postoperative diagnoses. For example, a preoperative diagnosis of intestinal obstruction and the postoperative diagnosis of ruptured abdominal aortic aneurysm. It was not an intestinal obstruction أصلاً. Okay. Adverse events or patterns of adverse events during procedural sedation, regardless of administration site. Adverse events or patterns during anesthesia, regardless of administration site. Adverse events related to patient identification. Other adverse events, for example, healthcare-associated infections and infectious disease outbreaks. Okay. Intense analysis of data takes place when adverse levels, patterns, or trends occur. Results of analysis are used to implement the actions, and then what? Implement the actions to improve the quality and safety of the service, treatment, and for the function. Now, we finished our first part of this lecture, which is related to the core components of the risk management. Now we are going to talk about the areas of the risk management. For the coming 8 areas that I considered as areas for risk management, this does not necessarily mean a need for extensive or comprehensive risk assessment for all of them. In some of them, maybe, but for the rest, just a simple assessment or even guidance for risk management is enough. احنا قلنا طبعا اللي هيفرق معانا ايه؟ هي sentinel event ولا لا؟ لو sentinel event لا، ده احنا هنعيش بقى في الريسك اسسمنت هنبهدل الدنيا. لكن في بعض الحاجات هنعملها simple assessment لو هي near miss or whatever. These areas, the infection control, the medications, and here the medications, there are 3 parts of it: patient-owned medications, sample medications, and medication administration during resuscitation. The third thing is suicide, then information security, laboratory safety, staff health and safety, clinical alarms, and the facility management system program. It talks about safety, security, hazardous materials and waste, fire safety, medical equipment, utility systems, emergency and disaster management, then construction and renovation. We'll talk in some details about these areas. Infection control. The hospital identifies areas at high risk for infections by conducting a risk assessment, develops interventions to address these risks, and monitor the effectiveness. The hospital completes and documents a risk assessment at least annually to identify and prioritize areas at high risk for infections. The hospital identifies and implements interventions to address infection risks identified through the risk assessment. But after the interventions, the hospital evaluates the effectiveness of these interventions and makes appropriate changes to the infection prevention and control program as needed. Then it performs ongoing data monitoring to ensure the risks are reduced and eliminated. هي نفس البروسيس بنعملها في كل حاجة، نفس البروسيس. هنidentify، هنكولكت داتا، هنلاقي فيه مشكلة، هنبدأ نعمل action plans، وبعدين هنعمل الانترفنشن ونبدأ نقيس بعد الانترفنشن ازاي data monitoring and نشوف هي فعلا حصل reduction or elimination للبروبلمز ولا لا. The same cycle يعني. The hospital has a process to protect patients and staff from blood-borne pathogens related to exposure to blood and body fluids. Identifies the processes اللي ممكن result of patient or staff exposure would implement practices علشان تقلل risk of that exposure. The second area is the medications. The medications احنا قلنا فيها 3 parts: patient own medications and sample medications, and finally medication administration during resuscitation. For the patient own medications, the policies and procedures govern medications brought into the hospital by the patient or family and medication prescribed for patient self-administration. The hospital performs a risk assessment for medications brought in by the patient or family that addresses where and when the medication was obtained and how the medication was stored at home. And this is in some areas called reconciliation of the medications. And this is a very important and critical point that's sometimes missed by many doctors, but it's really very important for preventing duplication of medications the same time or something, or adverse events from using medication and another antagonist. Reconciliation of medication is very important area. The second thing is the sample medications. There are policies and procedures govern medications brought into the hospital as samples. The hospital performs a risk assessment for sample medication brought in by the patient or provided by another source that addresses where and when the medication was obtained and how the medication was stored prior to arrival. Then the medication administration during resuscitation. Emergency medications are available, uniformly stored, monitored, and secure when stored out of the pharmacy. The hospital uses a risk-based approach and described in the intents to identify and implement strategies to improve the efficiency and accuracy of medication administration during emergency resuscitation. Then we're going to talk in the third area about the clinical alarms. Reduce the risk of harm associated with clinical alarms by developing and implementing risk reduction strategies for managing clinical alarm systems used for patient care. The hospital leaders develop and implement an alarm system management program for alarm signals that pose a risk to patient safety. A program identifies the most important alarm signals to be managed based on the risk to the patient safety. The second area here is the suicide. The hospital has a process to identify patients at risk for suicide and self-harm. The hospital conducts an environmental risk assessment that identifies features in the physical environment that could be used in the suicide or self-harm attempts. The hospital takes necessary action to minimize the risk. The fifth point here is the information security. The hospital maintains the confidentiality, security, privacy, and integrity of data and information through processes that protect against loss, theft, damage, and destruction. The hospital conducts and documents an annual information security risk assessment throughout the organization, and data security risks are identified and prioritized from the risk assessment. The hospital identifies goals, implements improvements to address data security risks, and monitors improvement data to ensure that risks are reduced or eliminated. The laboratory safety is our fifth area. A laboratory safety program is in place, followed, and documented, and compliance with the facility management and infection prevention control program is maintained. Identified safety risks are addressed by specific processes and devices to reduce the safety risk. The seventh area here, the staff health and safety. The hospital provides a staff health and safety program that addresses staff physical and mental health and safe working conditions. The staff health and safety program includes at least أول حاجة هنعمل initial employee screening, health screening. This is mandatory. Then measures to control harmful occupational exposures, such as exposure to toxic drugs and harmful noise levels. Then education, training, and interventions on what? Safe patient handling, managing workplace violence, staff who may be second victims of adverse or sentinel events, and finally, treatment for common work-related conditions such as back injuries or more urgent injuries. The hospital identifies areas for potential workplace violence and implements interventions to reduce the risk. The hospital provides evaluation, counseling, and follow-up treatment for staff who are injured as a result of workplace violence. The hospital provides education, evaluation, counseling, and follow-up for staff who are second victims of adverse or sentinel events. Then the hospital promotes staff well-being by creating a culture of wellness that supports physical well-being and emotional health. The last area we're going to talk about is here, the facility management and safety. The facility management and safety program, the hospital develops and documents a comprehensive risk assessment based on facility management safety risks identified throughout the organization, prioritize the risks, establishes goals, and implements improvements to reduce and eliminate risks. The risk assessment from all 8 facility management and safety programs are integrated to develop and document a comprehensive facility-wide risk assessment at least annually. الثمانية اللي اتكلمنا عنهم هم السيفتي والسكيورتي والهازاردس ماتيريالز اند ويست الفاير سيفتي والميديكال equipment واليوتيليتي سيستم والemergency and disaster management and finally the construction and renovation. The hospital prioritize the risks, identifies again the same, prioritize risk, identify the goals and improvements and implements the improvement to reduce and eliminate the risk. First part is the safety. The hospital develops and implements a program to provide a safe physical facility through inspection and planning to reduce risks. The results from the facility inspection are reviewed and addressed in a safety risk assessment that's conducted and documented annually, and safety risks are identified and prioritized from the risk assessment. Then the security. Again, the hospital develops and implements a program to provide a secure environment for patients, families, staff, and visitors. A security risk assessment is conducted and documented annually throughout the facility, and security risks are identified and prioritized from the risk assessment. The hazardous materials and waste, the hospital again develops and implements a program for what? For the management of hazardous materials and waste. A hazardous material and waste risk assessment is conducted and documented annually throughout the facility, and risks related to the hazardous materials and waste are identified and prioritized from the risk management. Fire and safety. Hospital has to establish and implement a program for fire safety that includes an ongoing assessment of risks and compliance with national and local codes, laws and regulations for fire safety. The hospital performs and documents an ongoing fire safety risk assessment related to the following, and fire safety risks are identified and prioritized from the risk assessment. First is fire separations, smoke separations, hazardous areas, fire exits, kitchen gases producing cooking devices, laundry and trash chutes, emergency power system and equipment, medical gas and vacuum system components, storage and handling of potentially flammable materials, procedures and precautions to prevent and manage surgical fires, fire hazards related to construction, renovation, and demolition projects. Now, we're going to talk about the medical equipment. The hospital develops and implements a program for the management of medical equipment throughout the organization. The medical equipment risk assessment is conducted and documented annually. Again, all here the same for the same process. Throughout the hospital, and medical equipment risks are identified and prioritized for the risk assessment. Utility systems. We develop and implement a program for the management of utility systems throughout the organization, and the hospital conducts and documents the utility system risk assessment annually throughout the hospital, and then you prioritize utility system risks and بتبقى identified for the risk assessment. The emergency and disaster management. The hospital develops and maintains and tests an emergency management program to respond to internal and external emergencies and disasters that have potential of occurring within the hospital and community. Now the hospital has identified the major internal and external emergencies and disasters such as community emergencies and natural or other disasters that pose significant risk of occurring, taking into consideration the hospital's geographic location. And finally, construction and renovation. When planning for construction, renovation, and demolition projects or maintenance activities that affect patient care, the organization conducts a pre-construction risk assessment. قبل ما نقعد نفحط في الحاجة نعمل الأول pre-construction risk assessment. بنأسس إيه for at least air quality, infection prevention and control, utilities, noise, vibration, hazardous materials and waste, fire safety, security, emergency procedures, including alternate pathways and access to emergency services and other hazards that affect care, treatment, and services. Again, the hospital takes actions based on its assessment to minimize risks during construction, renovation, and demolition projects and maintenance activities that affect patient care. The hospital reduces the risk of infection in the facility associated with demolition, construction, and renovation. The hospital has a program that uses risk creation to assess the impact of renovation or new construction and implements the program when demolition, construction, and renovation takes place. The hospital assesses the risk والimpact بتاع الحاجات دي على الاير كواليتي والinfection prevention throughout the hospital. The risk and the impact of demolition or renovation or construction are managed to protect the patients, staff, and visitors from infection. يبقى دي الجايد لاينز قصدي الريكوايرمنتس بتاعت الجي سي اي بتاعت الريسك مانجمنت. طب احنا في النص كنا اتكلمنا على احنا بنعمل ازاي اناليسيس للريسك مانجمنت، وقلنا من اهم النقاط اللي فيه هو الروت كوز اناليسيس، خصوصا لما بيكون فيه sentinel event. اوكي، هندخل على طول الليكتشر بتاعت ايه ده؟
دكتورة لميا استأذن حضرتك عشان صلاة العشاء.
اوكي تمام، حاضر. نصلي العشاء ونيجي نتكلم على طول في الروت كوز اناليسيز. الروت كوز اناليسيز ان شاء الله محاضرة ظريفة ولطيفة وتطبيقية اكتر من ان هي requirements، فان شاء الله هتبقى سهلة يعني.
بإذن الله. خلاص إن شاء الله نرجع الساعة 9 مناسب؟
طيب يعني
9
ينفع نخليها 10 دقايق
9 ل 10.
نخلص على طول.
طيب حاضر، طيب تمام، يعني
نقصر
10 دقايق
الفيديو.
ونرجع.
يا ريت ان شاء الله، علشان
تمام.
علشان الناس بقى تاخد راحتها وكده ان شاء الله، ما نطولش عليهم النهارده.
خلاص بإذن الله. لا 10 دقايق ونرجع يا جماعة، مش هنقعد
ايوه
9 و10. ايوه
بالظبط،
يعني
10 دقايق
يعني
نصلي
دلوقتي
العشاء ونرجع.
35 يعني 45 يعني 9 8 45 ان شاء الله نرجع باذن الله.
يا ريت، خلاص ان شاء الله.
تمام عشان نخلص بدري ان شاء الله. شكرا يا دكتوره.
تحت امرك.
عشان كلهم عايزين يخلصوا بدري يا دكتوره، الله يسعدك.
ايوه بالظبط، خلاص ان شاء الله. لا ان شاء الله دي تعدي سهله بامر الله.
شكرا يا دكتوره. خلاص الساعه 8:45 باذن الله هنرجع. دلوقتي بريك صلاه. ان شاء الله نخلص بدري باذن الله. الدكتوره بقى لها محاضره واحده ونخلص ان شاء الله. استاذ حسين ان شاء الله الساعات تنزل ممكن من 3 ل5 ايام. إن شاء الله. لا لسه ما خلصنا جماعة، بريك صلاة 5 دقايق والدكتورة تدخل. أستاذة ميسة سجلي النهاردة، أرسلت لكم رابط التسجيل تقدروا تسجلوا عليه دلوقتي. اللي ما سجل النهاردة اثبتوا. أربعة هنبدأ المحاضرة الأخيرة، وهتسجلي برضو مرة واحدة. لا قبل 5 أيام تنزل الساعات إن شاء الله. ده من الهيئة يا أستاذة غيداء، مش من عندنا. احنا لو علينا ننزلها لكم والله على طول، من الهيئة السعودية. هو مش بعد 5 أيام يا أستاذة غيداء، من 3 ل5 أيام إن شاء الله بإذن الله. يعني خلال 5 أيام تكون نزلت الساعات. واضح؟ شكرا يا أستاذ بندر. أستاذ عبد القادر لازم تسجل الحضور قبل ما تخرج من المحاضرة النهاردة. العفو يا أستاذ إبراهيم، أهلا وسهلا بيك. لا حضرتك تسجل مرة واحدة بس، مش بعد كل بريك، مرة واحدة في اليوم بتسجل. الله يعافيكم جميعا. لا لازم تسجل 3 أيام تسجيل حضور، يعني بكرة إن شاء الله نفس الحكاية تسجله.
السلام عليكم.
عليكم السلام يا دكتورة.
نبدأ كده آخر محاضرة، خلص بقى كده إن شاء الله سريع سريع. بس إن شاء الله المحاضرة دي أنا محتاجة بقى نركز فيها حلو كده، إن هي فعلا محاضرة مهمة جدا. كلنا على كل المستويات هنستخدمها كتير في شغلنا، فيا ريت نكون فاهمين الستبس بتاعتها كويس إن شاء الله. مش كلنا هنحضر السيرفيز بتاعت الGCI ولا بتاعت السباهي، لكن كلنا هيبقى محتاجين نعرف الروت كوز اناليسيس بيتعمل ازاي. اوكي، بسم الله. طيب احنا ليه هنتكلم على الروت كوز اناليسيس؟ ايه الهدف اصلا من ايه الهدف من الليكتشر دي؟ هنشوف what, why, when, how and who. what ايه؟ what's the root cause analysis? root cause analysis the method of problem solving used for identifying the root causes of faults or problems، ودي widely used في الاي تي طبعا، بس احنا كمان بنستخدمها كويس. بنستخدمها ادي عندنا هنا problem واضحة above the surface، احنا شايفين السيمتومز بتاعت البروبلم. احنا عايزين نعرف بقى ايه الروت causes of that problem علشان اعرف eliminate البروبلم دي اصلا. فانا محتاجة dig deeper عشان الاقي the root causes of the problem. root cause analysis is often used in proactive management. احنا قلنا النهارده كلمة proactive دي كم مرة؟ هو الهدف اصلا ان احنا نبقى بنشتغل proactively، نتعلم من اخطائنا السابقة ونعمل action plans بحيث ان احنا ما نغلطش الاخطاء دي تاني. وكمان نتجنب اخطاء اخرى ان هي تحصل اصلا. proactive management to identify the root cause of a problem that is the factor that was the main cause of that problem. It's customary to refer to the root cause in singular form رغم إن ممكن يكون في أكتر من factor, but one or several factors may in fact constitute the root cause or causes of the problem under study. It's a useful process for understanding and solving a problem. And we use it to figure out what negative events are occurring, then look at the complex systems around those problems and identify key points of failure, then finally determine the solutions to address these key points or root causes. How does it differ from what we do now? What's our usual approach now? Here, the problem is identified, then I bring my gun and firefighting, immediate containment action implemented, problem reoccurs elsewhere, I'll find someone to blame and shoot him. Okay? What's the preferred approach? That there is a problem identified, then I have to do a correction action now, immediate containment of the action, containment action implemented. Okay, I contain the problem here. Then I have to define the root cause. Then I will find solutions, and these solutions are validated with data. Then these solutions are applied across the company, and guess what? It will never return again. This problem will never return again. That's the difference between our usual approach and what we want to do with using the root cause analysis process. How does it work? There is a defect found هنا عند الكاستمر. اوكي، انا عملت البروسيس والبروسيس مشت وصلت للكاستمر في ديفكت. اوكي، الكاستمر ده ممكن يكون internal customer او external customer، حد من الستاف او external customer. طيب البروسيس ماشيه بخطوات. هنا حصل الديفكت من اول البروسيس بي، يعني انا كان ممكن الحق الموضوع هنا. طب انا ليه سبته يوصل لحد الكاستمر؟ طب انا عايزه ايه؟ انا عايزه contain the problem، يعني البروبلم حصلت هنا، فاحنا هنمسك بقى الحته دي كلها ونعمل containment للبروبلم قبل ما توصل للكاستمر. Nothing's allowed to further escape to the customer. لم المشكله قبل ما ايه؟ ما توصل للكاستمر. طيب اللي بعد كده احنا عايزين ايه المفروض؟ احنا عايزين بس نكونتين الروت كوز. انا عملت روت كوز اناليسيس ليه؟ علشان اكونتين هنا اهو في البروسيس اللي فيها البروبلم. مش هسيب الدنيا كل، لا، امسك بقى احدد هي فين البروسيس اللي فيها البروبلم وايه الروت كوز بتاعها، فاكونتين الروت بروسيس. Nothing is allowed to further escape to the next process, not just to the customer. No, nothing's allowed to escape to the next process. Then finally, I will try to prevent the problem by knowing the root causes that led to the problem here in the process B. So corrective action implemented so root cause of problem does not occur again. خلاص شلت البروبلم خالص. وهو ده اللي احنا عايزينه من الليكتشر بتاعت root cause analysis. طب who's to blame؟ يعني احنا لما هنعمل دلوقتي root cause analysis كده هنمسك مين نفنطه؟ The no blame environment is critical. Most human errors are due to a process error. مش احنا اتفقنا على كده؟ اغلب human errors بتبقى فيها system error أو process error. A sufficiently robust process can eliminate human errors. Placing blame does not correct a root cause situation. Is training appropriate and adequate or not? Is documentation available, correct and clear or not? Are the right skill sets present or not? What about the corrective actions? We have 3 types of corrective actions. Either immediate action, the action taken to quickly fix the impact of the problem so the customer is not further impacted, like here, the immediate action علشان ما يوصلش للكاستمر ده هي contain the problem. Then the permanent root cause corrective action, the action taken to eliminate the errors on the affected process or product. Here I will contain the root process. Then the preventive or systemic root cause corrective action, the action taken to prevent the error from recurring on any process or product. Here, I prevent the problem, the preventive action. How to conduct root cause analysis. Root cause analysis process, it takes some steps. The first step is define the problem, then collect data, definition of the problem. I'll collect data about it. I'll identify the possible causal factors. I'll identify the root causes, then recommend and implement solutions. This is the problem-solving process. We start by identifying problem, identify the team, immediate action, root cause, then the action plan, complete plan, then follow up and validate. Step 1, identify the problem. Clearly state the problem the team is to solve. أول حاجة لازم أعرف إيه هي البروبلم and what's the meaning or what's the definition of that problem. Teams should refer back to problem statements to avoid getting off track. ما اقعدش احاول احل في حاجة لازم نكون متفقين على statement of the problem علشان ما نقعدش نتشتت. Ensure your identity. You identify the problem and align with the customer need. If not existing, anticipate the problem from a customer perspective. What are the specific issues you observe? What happens if you do not tackle the problem now? What's the business impact? احنا كده بنتكلم على ان احنا ايه؟ proactive. هنبدأ نcollect data relating to the problem. Is there data to support the specific problem? هل في data أصلا موجودة ولا لأ؟ Support the speak to customers and employees if possible and seek their advice. Is it a recurring problem ولا لأ? How frequent in the past? What's the measurable impact of the problem on key customer outcomes? And here you should use the 5W2H approach. Okay? طرق الداتا collection بالobservation مثلا، بالinterview، زي ما اتكلمنا كده على السيرفيز بتاعت الجي سي اي والسي بي اي، قلنا بيعملوا ايه؟ قلنا بيشوفوا الدوكيومنتيشن، ادي هيبص اهو على الداتابيز، هيعمل observation، هيلف في المستشفى نفسه ويشوف، هيعمل انترفيوز مع اللي هو ستاف انترفيوز، نفس طرق الداتا كولكشن. احنا هنعمل نفس الطريق observation, interview, questionnaire and database. طيب هعمل ايه؟ هستخدم ال 5W: who, what, why, when and where. وال 2H approach: how and how many. Who: مين ال individuals associated with the problem. What: what's the problem statement or definition. When: the date and time problem was identified. Where is the location of complaints? Why? Any previously known explanations? How? How did the problem happen? Yani the root cause. And how will the problem be corrected? What's the corrective action now? And how many? To know the size of the problem and the frequency. يبقى كده أول step 1 كانت إن إحنا بنعمل identification للproblem. Then I will identify the team. When a problem cannot be solved quickly by an individual, we have to use a team. The team should consist of domain knowledge experts. With a small group of people from 4 to 10 with process and product knowledge, available time and authority to correct the problem, and must be empowered to change the rules. And they should have a designated champion. Membership in team is always changing. What are the rules and the responsibilities of the team? The champion is the mentor. He will guide and direct the teams, advocate to upper management, and here the leader has to do the day-to-day authority, calls, meetings, facilitation of team, and reports to champion. The record keeping writes and publishes the minutes, and the participants respect all ideas, keep an open mind, know the rule within the team. When now we identified our team, then we will start in the next step is the immediate action. We must isolate effects of problem from customer. لما احنا علمنا كده على 3 processes اللي في النص عشان ما نوصلش للكاستمر. هنا ال immediate action usually band 8 fixes. ألم الموضوع كده وأعمل band 8. 100 sorting, 100% sorting of parts, re-inspection before shipping, rework, recall parts. طبعا هنا بالنسبة للإيه؟ للحاجات الانسترومنت يعني الحاجات الصناعية وكده industrial يعني. المهم إن هي ما توصلش للكاستمر في الآخر. Only temporary until corrective action is implemented. ودي طبعا بتبقى مكلفة جدا but it's necessary قبل ما يحصل adverse event ولا حاجة. And must also verify that immediate action is effective. Immediate action يعني activity implemented to screen and or contain the problem. It must verify that immediate action was effective. هعرف ازاي؟ بعمل pilot test. I make sure another problem does not arise from the temporary solutions. Then I'll ensure effective screens and detections are in place to prevent further impacts to customer until permanent solutions are implemented. Then we will go to the step 4, which is the root cause. How are we going to process this root cause? First step is brainstorming. Brainstorm possible causes of problem with team. التيم هيقعد مع بعضه وهيبدأوا كل واحد يدي الاقتراحات ممكن تكون الأسباب إيه. نعمل brainstorming. هنorganize the causes with cause and effect diagram. نستخدم الباريتو the causes to identify those most likely or occurring most often. نستخدم ال 5 whys method. دي كلها طرق علشان ال root cause. قلنا ال fishbone أو ال cause and effect. الباريتو ال 5 whys to further define the root cause of the symptoms. Use may involve additional research, analysis, investigation to get to each why, and must identify the process that caused the problem. If root cause is company-wide, elevate these process issues to upper management and address. طيب التولز زي ما اتفقنا brainstorming, flow charting, cause and effect diagram, Pareto charts, barrier analysis, change analysis, 5 whys, failure mode and effect and critical analysis, and fault-free analysis. Here are some examples of the root cause analysis tools for more effective problem solving. This is the flow chart. This is a sample for flow chart. You start here, process and decision. If كذا yes, we will move here. If no, we will move here. This is a sample of the flow chart. This is a sample for the fishbone diagram. Okay, we take here the opinions. We do brainstorming and put the causes and يعني collect every cause and how to reach هنا the effects, the cause and effect. That cause led to the effect here. A cause and effect, also called Ishikawa or fishbone diagram, is a data analysis process management tool used to organize and sort ideas about causes contributing to a particular program or issue, gather and group ideas, encourage creativity, break down communication barriers, and encourage ownership of ideas, overcome infighting. A cause and effect diagram is typically generated in a group meeting. It's a graphical method for presenting and sorting ideas. هي الفكرة فيه إن إحنا بنسورت الأيديز ونحطها كلها إيه؟ كل مجموعة شبه بعض مع بعض. About the causes of إيه؟ of issues or problems. This is the causes are not limited to the 5 listed categories. The main categories here: environment, materials and methods, equipment and people. The steps used to create a cause and effect diagram is to define the issue or problem clearly, decide on the root causes of observed issue or problem, and brainstorm each of the root of the cause categories, and write the ideas on the cause and effect diagram. Okay. After completing the cause and effect diagram, take the following actions. We will rank the ideas from the most likely to the least likely cause of the problem or issue. Then we will develop action plans for identifying the essential data, resources, and tools. What are the expected outcomes? Individuals have become part of a problem-solving team. The sources of problems and other issues have been identified using a systematic process. Team members see issues from a similar perspective. Ideas and solutions are documented. Communication is improved. Then team members assume ownership. طب بعد ما عملنا الكوز اند effect وشوفنا كده ممكن اكتر كوزز هتكون فين، ببدأ اجمع الداتا بتاعة النمبر of the causes. يعني كل كوز يعني مثلا انا لو عندي 100 ملاحظة كان فيهم 70 الكوز بتاعهم كان كذا و30 الكوز بتاعهم كذا، يبقى انا ببدأ اعمل sorting للكوز ده اتكرر معايا كم مرة، وابدأ اجمع الداتا دي واعمل بيها الباريتو دايجرام. هنا مثلا كان عندنا عدد من الكوزز 37 35 21 18 13 وهكذا، ولسه في other causes عملنا لهم sorting. المفروض ان التوتال من الكوزز دول كده كانوا بالنسبة لنا 51% من الكوزز اللي احنا جمعناها، أو يعني من الملاحظات اللي جمعناها. فال37 دي تمثل 13% من التوتال. المفروض طبعا الخط الأحمر ده بيبدأ هنا 13%، وبعدين لما أضيف عليه ده كده بقينا 26%، كده بقينا 34%. فأنا يعتبر بالنسبة لي إن الفيرست 3 كوزز دول مثلوا لي 34% من الكوزز بتاعت المشكلة. يبقى أنا لو حليت ال3 دول بس أنا كده تخطيت أكتر من تلت المشكلة، عرفت أحلها. طيب what are the 5 whys analysis? We ask 5 questions, not just 5 questions beginning in why. لا ده هم مترتبين على بعض. طب each question must lead to the next. why ده فيزقني على why اللي بعده، فيزقني على why اللي بعده. ask why 5 times. امتى هوقف؟ stop when the corrective actions don't change. يعني انا وصلت why. طب انا لما هعمل كده هكوركت بايه؟ بالطريقه الفلانيه. طب why الكوركتيف اكشن اختلف؟ لا، هي نفس اللي هعمله corrective action. يعني خلاص يبقى انا كده هوقف why بقى. يبقى انا وصلت للcorrective action، يبقى ابدا اطبق corrective action. stop when the answers become less important. مبقاش مهمه بقى. stop when the root cause condition is isolated. Okay. The other tool is the failure mode and effect analysis. أنا بقول الفيلير مود إيه هو، وبقيسه على الحاجات المهمة بالنسبة لي وأوزنه. السيفيريتي بتاعته إيه، البروبابيلتي إن هو يحصل أصلا إيه، البروبابيلتي إن أنا ألاقيه إيه، الريسك ريفرنس بتاعه قد إيه. بناء عليه يبقى ده يهمني ان انا اشتغل عليه ولا لا. وده برو اكتيف. هو ما حصلش لسه، هو فيلير مود. هو انا ايه برو اكتيفلي، انا بشوف المشاكل اللي ممكن تحصل ايه وابدا اشتغل عليها. ولو هي الوينج بتاعها تقيل ومهمه وممكن تعمل لي مشكله كبيره، يبقى دي بتبقى البروجكت بتاعي هشتغل عليه. مثلا بالنسبة للميديكيشن ايرور مثلا هعمل له root cause analysis. ممكن يكون الأسباب عندي man or material or measurement, machine, method and equipment. اوكي. في الآخر الإيفكت حصل إيه؟ حصل إن في wrong medication administration led to severe DKA and increase length of stay to 28 hours. اوكي. طب الأسباب كان عندي إيه مثلا؟ lack of information, not following the prescription policy, not follow communication commands, lack of communication between the pharmacy and the doctor. دي في methods. wrong administration of insulin which must receive subcutaneous مش IV, non-availability of the route of the medication on the label of the insulin, whatever. So all these causes led to the effect, and I'll measure and يعني the most important of them and start like a Pareto diagram or whatever after collecting data and act on the most important repetitive causes to improve or to prevent that effect. Then the corrective action. Step 5 is the corrective action. We must verify the solution. Will eliminate the problem. Verification before implementation whenever possible. Define exactly what actions will be taken to eliminate the problem and who is responsible, when will it be completed, and make certain customer is happy with the actions. define how the effectiveness of the correct action will be measured. أهم حاجة عندنا الإيه؟ الميجرمنت. verification verification versus validation. قبل كده كنا بنستخدم ال verification اللي هو بنassure that at a point in time the action taken will actually do what is intended without causing another problem. لكن now validation provides measurable evidence over time that the action taken worked properly and problem has not occurred. The next step, we are still in the complete action plan. Step 6, complete the action plan. Make certain all actions that are defined are completed as planned. If no task is still open, verification and validation is pushed back. Then, if the plan is compromised, most likely the solutions will not be as effective. Then, we will follow up the plan. What actions will be completed in the future to ensure that the root cause has been eliminated by this corrective action? Who will look at what data? أنا هفولو up البلان ازاي؟ ايه الاكشنز اللي هتبقى completed؟ مين اللي هيتابع الاكشنز؟ لحد امتى؟ How long after the action plan will this be done? And what criteria in the data results will determine that the problem has not occurred? Finally, the last step is to validate and celebrate. What were the results of the follow-up? If the problem did recur, go back to step 4 and re-evaluate the root cause and then re-evaluate corrective action in steps. Step 5. If problem did not occur, celebrate team success. Then document savings to publicize team effort, obtain customer satisfaction, and continued management support of teams. What does a good RCA look like? The root cause is internally consistent, thorough, and credible. What's the meaning? The complete root cause analysis is interdisciplinary, involving experts from the frontline services, involving those who are the most familiar with the situation, continually digging deeper by asking why at each level of cause effect, a process that identifies changes that need to be made to system, a process that's as impartial as possible. To be thorough, a root cause analysis must include determination of human and other factors, determination of related processes and systems, analysis of identifying cause and effect systems through a series of why questions, identification of risk and their potential contributions, then determination of potential improvement in processes or systems. To be credible, a root cause analysis must include participation by the leadership of the organization and those most closely involved in the process and system, and be internally consistent. Hence, about the root causes, one problem may have more than one root cause. One root cause may be contributing to many problems. When the root cause is not addressed, expect the problem to reoccur. Then prevention is the key. We talked in the previous lecture about the sentinel event. Here is a small talk about it. The sentinel event is any unanticipated event in the healthcare setting resulting in death or serious physical or psychological injury to a patient or patients not related to the natural course of the patient's illness. وقلنا الفرق بين السنتينل ايفنت والادفيرس ايفنت ان السنتينل الادفيرس ايفنت هو unanticipated, undesired or potentially dangerous occurrence in a healthcare organization. It's if this incident involves death or serious physical and psychological injury, it's a sentinel event. With sentinel events like invasive procedure, including surgery on the wrong side, wrong patient, or wrong procedure, unintended retention of foreign objects. اتكلمنا على السويسايد و discharge of infant to wrong family والabduction. هنا اشتغل في wrong eye. ده ال GCI report. From بيتكلم هنا على wrong side surgeries documented by the GCI من 1995 ل 2008. Okay, if we talk about this هنا على مدار 13 سنة، لا احنا خلاص خلصنا خلاص يعني don't worry. على مدار 13 سنة عندنا 691 wrong side surgery يعني almost 53 per year. 470 major medication errors resulted in death or permanent disability. 7 cases of endorsement of wrong baby. 119 incidents of wrong blood transfusion, wrong matching. 58 incidents of retained surgical item in the patient's abdomen. And these numbers are huge and needs actions. So errors or potential errors in the healthcare, we said that at-risk behavior, there is a probability of the error to happen, but it didn't reach the patient and it was not harmful. The near miss, it could happen, but it didn't reach the patient or it was not harmful also. Here the adverse event, the error happened and the error reached the patient, but it could be harmful. And the sentinel event, it caused a major harm. And this is the one we are obligated to do root cause analysis for. Errors or potential errors in the healthcare, as we said, for at-risk behavior, no need more than awareness. For near misses, we need to report, we need to collect data, and we need to do some awareness, but we will not need RCA unless if it may lead to a sentinel event. For the adverse event, we have to report and collect data and do awareness. And if repeated, we have to do a root cause analysis. For the sentinel event, sure, we have to do a root cause analysis. What's the goal of the Joint Commission policy on sentinel events? Help hospitals to improve safety and learn from those sentinel events. Help the analysis of patient safety events for evaluation of corrective actions to reduce risk and prevent patient harm. To protect the patient, improve systems, and prevent further harm. Now, A very big thank you to all of you. It was really for me a very amusing day. I was happy to join you today, and I hope that the lectures were not too heavy and you got a benefit from that. And inshallah, see you back at many more lectures. Please, if there is any question, don't hesitate to ask me. جزاكم الله خيرا جميعا، وشكرا جزيلا